we still have witnesses we would like to talk to them about.
Okay, well, let's make our record. You know, I can only go on things. You have a 403 issue going on here, we can deal with it.
Okay, thank you, Judge.
It eventually becomes cumulative. Is it relevant? Is the probative value, is it outweighed by the prejudicial effect?
Well, Judge, and I would just remind you that if this was one instance, yeah, I would concede that point.
I'm well aware we have 14 counts.
And you know, so all of these witnesses are like brand new as to an issue. So it's not cumulative as to these cases, to the counts they're testifying about.
Judge, I thought that's why the court took the time out away from the jury, and the jury had to be waiting in the jury room while we resolve these issues. What's the point of taking time to resolve these issues if you can come back after the weekend and say, well,
okay.
I didn't agree to anything.
I understand what you're saying. Okay? It wasn't the reason I took the time out. Okay? So that aside, you know, we're just going to have to play it through, I guess. So I'll note everybody's objections, their comments. I'll let everybody prop the record, but I want to get this jury going.
We would have ask for a standing objection to any of these topics being broached, so that I'm not drawing extra attention to it already by the constant objections.
Well, I think everybody understands what the issue is, and I think the Court of Appeals has enough foundation to deal with it. We're just going to have to play it by ear. And let's see where the questions go.
Yes, sir.
Okay.
All rise.
You may be seated. Good morning, ladies and gentlemen of the jury. Just so the parties know, Mr. Petticoat was gone this morning because of a family issue. I had to look the jurors in, so I actually have to talk to a couple of them. Good mornings, that was about it. I didn't talk about the case, did I, guys?
No.
So, with that, Mr. Zion, call your next witness.
Thank you, Your Honor. The state of Ohio calls Jake Deemer to the stand.
Y'all have a good weekend? Y'all look pretty rested. You. That's different. I was yeah, well, Sunday night, I think I slept 10.5 hours. So when I got up, it was late afternoon. It's a good thing. Okay. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God.
Yes.
You're going to make yourself comfortable. You can lower your mask if you like. Okay, you got that aerial mic there in front of you. I need you to state your name for the record and spell it so that my court reporter can get your diction.
My name is Jacob Deemer. It's Jacob, last name Deemer.
Okay, can you guys hear him? Yes. Okay. You want a little volume? Little volume, okay?
Yes.
You can yell us. It's okay.
Yes.
Mr. Zion.
Thank you, sir. Can you please tell us, where did you grow up?
I grew up around Pittsburgh, Pennsylvania.
And what college did you go to?
I went to Capital University from 2012 to 2016.
What did you study at Capital University?
I got my bachelor's in science degree in nursing.
All right. Tell us about your training that you went through at Capital University to do what you to get that degree.
Yeah, so Capital, obviously you have your coursework. You study basic intro level stuff to nursing and healthcare, but then also you couple that with some clinical where you sort of have a residency, if you will, at various hospitals around Columbus. Respectfully, I enjoyed my time at Capitol. However, you really learn a lot on how to do your job on the job. So Capitol was more of getting your feet wet.
Well, tell us about your clinical experience while studying. What, if any, hospitals locally did you study at while at Capitol? Yes, I did. My first clinical was at Mount Carmel East. I rotated through Riverside. I did OB, maternity infant at Riverside. I did community health, and then I also did a preceptorship experience, which is where they pair you and shadow you with a nurse. And I did that at Grant in their trauma bay.
All right. At some point, did you wish to do a preceptorship in the ICU while studying to be a nurse?
Yes.
And were you able to do that while studying to be a nurse?
No.
Okay. Did you want to work eventually in the ICU?
Yes.
All right. So what year did you graduate nursing school? The Capitol with a degree in, it's an MS, Master's of Science?
No, so the first one's a Bachelor's of Science in Nursing. It's a 4-year degree, so I graduated in 2016.
All right. And did you thereafter take a test, a board, to become a nurse licensed in practice in the state of Ohio?
Yes, it's a NCLEX RN.
Say that for the record reporter. Spell that out.
NCLEX, NCLEX-RN. It's our licensure examination.
And when did you take that in 2016?
A couple months after I graduated, so maybe, I graduated in May, so maybe July, roughly.
Did you thereafter get a job somewhere?
I did.
Where did you get the job?
Mount Carmel West.
And what position did you apply for, and what position did you get?
I became an ICU registered nurse at Mount Carmel West.
Did you apply for, or were you assigned a particular shift as an ICU registered nurse at Mount Carmel West?
So I worked the night shift, sort of by choice, but also by need. On the night shift, there's tend to be less resources in the terms of people in-house, so it's a little bit slower for new nurses, so you can kind of focus on your patients, but then also there's less distractions, and you get paid a little bit more, and I wanted to make more money.
Makes sense. Brand new. So this is your first job as a nurse. And when month you took your test, and you estimate July of 16. When are you starting your job at Mount Carmel?
Maybe September. Shortly thereafter, it was contingent. My job beginning was contingent on me passing that board examination. So the onboarding process started shortly after I passed. The exact month escapes me anymore.
Okay. Tell the jury about your onboarding process with Mount Carmel. Was there an orientation period? Did you work other shifts, etc.?
So yeah, so there was technically an orientation period. It consisted of shadowing other nurses. Basically, it was should have been in theory, a methodical way to introduce concepts and how to do your job to a new nurse, specifically any nurse, but also a new grad orientation. You would primarily follow around a nurse on the day shift, and then on the night shift, although I did do some days. But it's important, I guess, that Mount Carmel recognized the preceptorship experience as everybody being one nurse. So since I really had a minimal understanding of having never worked in a hospital, they would pair me with an experienced nurse, and I was basically tethered to that nurse. So anything that I did, they would sign off on, or anything that she did or he did, I would learn from that. So although 2 licensed RNs, we were considered one entity for the patient.
You said in theory it should have been a methodical introduction as to everything you would need to know. Did you find that to be what actually occurred during your orientation period?
No.
Explain that, please.
So there's a couple things. The first is there's always a nursing shortage. However, I was actually approached, I believe it was a 10 to 12 week orientation. I was approached, I believe, after week 8 by my manager, and the manager basically asked me to come off orientation early, and I expressed some concern about that, but she said that she would give me easier assignments, one patient, but basically my orientation was cut short to help staffing issues.
All right.
And being that Mount Carmel West is a mixed ICU, meaning that you can see medical patients, surgical patients, trauma patients, et cetera, it's not possible to see every type of patient in 8 or even 10 weeks. So there was something left to be desired for the orientation process.
So talk about how you felt experience-wise when you started. So if you started in September of 16, you passed your test and you're doing this orientation. Are we now into October, November, and you're on your own, basically?
Yeah.
All right. Talk about how comfortable you felt with the level of experience and training you had when you first started in the ICU on your own after 8 weeks of this orientation.
Yeah, I think it's relative. If there was a patient who had orders to leave the floor, I was comfortable with that. Basically very stable patients I was comfortable with, but there always was a little bit of apprehension. But I knew that I could go to my coworkers and ask for help. But I told them in advance in the huddles that I might be asking a lot of questions.
Okay. Talk about your understanding of the level of experience of your coworkers in general in the ICU back when you started.
So the charge nurses tended to be more experienced. Several come to mind that had 10, 15 plus years of experience. I would say most of the people were 5 years or less were working on that unit, but there were nurses that had tons of years of experience, but there were far more newer nurses than there were, 30-year veterans or something like that.
All right. And when you say newer, could you estimate, in your mind, your understanding, when you say newer, is that 5 years or less, or even less than that?
For me, I felt comfortable, really comfortable, and felt like I could teach other people at about 1.5 years. So I would say, when I say newer, I would say like between 1 and 3 years of experience.
All right. Did you have aspirations to continue in your education and seek a higher level of nursing certification when you started on this journey, started working at the ICU in 2016?
Yes.
What is that aspiration that you had?
To seek a career in nurse anesthesia. It's called a Certified Registered Nurse Anesthetist, or a CRNA. That was my goal from a very young age.
And would that require you to gain experience and then go and get more schooling, more education?
Yes.
All right. So this is something you had in mind when you started in 2016?
Correct.
All right. So tell us about, once you were past orientation, did you work exclusively on the night shift then?
Yes.
And tell us about what doctors you would work with on the night shift in the ICU at Mount Carmel West.
There were 2 doctors, Dr. Hagris and Dr. Husel.
All right. And did they seem to split the ICU, their time between the 2 of them evenly?
Yes.
All right. In your experience, did you find that you were working more with one of those 2 particular doctors?
It's hard to say. I would say maybe 60-40, but it depends. What I can say is I never put my work shift to line up with any of the doctors. It was organic when I worked. So I worked with them. Some days I would work with Dr. Husel 3 in a row, and then I wouldn't see him for 2 weeks. Other days I'd work with Dr. Hagris. So I can't say. Maybe 50-50.
Okay. Do you recall at a previous hearing saying that you, for whatever reasons, like organic, you've just described, you would tend to, in your mind, you had worked more with Dr. Husel?
Yeah, I remember saying that. I guess like if you're asking me to put a percentage on it, I can't. So, I mean, maybe shortly when I was asked that question, I don't know. I don't know. I would say that Dr. Husel seemed to work more shifts than Dr. Hagris. That's what I can say.
Okay. On a personal and or professional level, did you have a closer relationship with one of those two doctors?
Yes.
And which two of those doctors did you have a closer professional and personal relationship with?
Both, but number one was Dr. Husel.
And can you describe what, if anything, in your mind, attracted you to, in a professional sense, Dr. Husel?
Yes. His first and foremost, when I was orienting on the day shift, it was common knowledge, or at least it appeared to be common knowledge, that there was a doctor on the night shift who was very good, knew his stuff, highly educated, highly trained, and he would be a very good resource to learn, especially being new. Second, he was in anesthesia, and I had aspirations to go to anesthesia school, so I thought it would be, so here's a highly accomplished professional with training at the Cleveland Clinic who is doing the thing that I want to be doing, or something similar, and he's apparently very good. I should probably figure out why he thinks the way he thinks and learn how he does the things that he does, because it's led him to a great deal of success. So I like to copy people who have walked the path before me, because usually they're on to something.
Tell us about your understanding of the reputation of the Cleveland Clinic. You mentioned that by name, that he was trained as an anesthesiologist at the Cleveland Clinic.
Yeah, I can speak to it. I've actually trained there as well. It has a reputation for being a place where people who are very sick go. There aren't many hospital systems around here that are better than the Cleveland Clinic. In fact, people come from around the world to go there. So that's a pretty highly prestigious institution.
And this was something known to you and to others regarding Dr. Husel's background?
You mean where he trained? Mm-hmm. Yeah.
Okay. Were you aware of any awards that he had won previous to your employment?
I'm not sure previous to the employment, but I did know, and I came to know at some point, that he was voted, I believe it was Mount Carmel Physician of the Year.
And are you aware if this was something that was, that award was nurse-driven? This was something that the nurses would vote on to?
No.
Okay.
I didn't know how they came to that.
All right. What that was like, just to lay a foundation for your relationship with him.
I'm not sure if I remember the first time I met him.
All right. What's the first interaction that you do recall?
Yeah, I remember he came up to me. It was a slower night for me being new, and he pulled me into my patient's room, and he said, hey, this patient's on a ventilator. If I want to control ventilation or CO2, what numbers would I manipulate on this ventilator? And I missed the question. I had no idea, to be honest. And he educated me. And I, although respected, I always research for myself, so I had gone home later that night. I bought books to study on my own time, and I basically read about the things that he said, and it turned out to be true. So I just remember being educated about something.
But on his own, he came to you, took you aside, and took this time out of his schedule to help you.
Yeah, he did that with everybody.
All right. Would you ever talk to him about anything that wasn't work-related? Did you ever, did you feel you had a relationship with him otherwise?
Yes.
Tell us about that.
Him and I have mutual interests in fitness, so we would talk about lifting. We would talk about basketball. We would talk about the game the night before. We would talk about the Twilight Zone episodes. He was very approachable, but it was in a, well, he was very approachable.
All right. Did you two ever have socialized outside of work?
To my knowledge, no. We had talked a couple times, but those things were just talk.
Did you consider him a mentor?
Yes.
Did you describe his professional relationship being around him as more of an extended sort of preceptorship?
100%, yes.
And in fact, a preceptorship that...
Objection, leading.
Rephrase.
How would you describe this extended sort of, did you receive this type of extended sort of preceptorship in college?
I'm not sure I understand.
Did you receive this type of training that he was giving you in college?
No. In my experience, there's not many nurses who, ICU is such a wasn't likely to encounter any of these concepts in a trauma bay at Grant.
Okay. So what you're learning about the ICU and how it functioned is from your professional relationship, this mentorship with Dr. Husel.
Not mutually exclusive, but yes, he is part of that. There's other nurses, other doctors, even respiratory therapists. They're all helping to sort of educate me. But when it comes to educating, he was the only guy who would come up to you and be like, hey, if you have 5 minutes, name anything in this ICU and let's talk about it. I've seen him do that with respiratory therapists as well, and techs, people going to nursing school.
Did Dr. Husel ever write you a letter of recommendation?
Yes,
What did he write you a letter of recommendation for?
an application to get into anesthesia school.
All right.
I also received a letter from Dr. Hagris as well.
Okay. All right, let's talk about your training and knowledge at the time about
Yeah.
narcotics and benzodiazepines. Let's start about the extent of the training you received at Capital University, either in the classroom and or on the job regarding narcotics and benzodiazepines.
Very little. At Capital, we took one pharmacology class. I believe it ran for the duration of my junior year. Excuse me. And what it encompassed was basically talking about the group of medications and not actually discussing specifics about medications. So she would say narcotics, drugs you may encounter could be Dilaudid, morphine, fentanyl, but we never actually broke down the differences between the two. It was like you basically covered one group of medications twice a week, and then you moved on to the next one. So very little to answer your question.
Did you recall at a previous hearing describing it as almost none?
Yeah, I would say that's pretty much almost none.
Okay. So walking into the ICU in the fall of 2016, you have almost none as far as training in the use and application of narcotic pain medication and benzodiazepines.
I had given some, in my clinicals, but if you're I was unable to break it down on a pharmacological level as to how they worked.
Are you familiar with package inserts for these drugs?
I am.
And can you tell the ladies and gentlemen of the jury what a package insert is for these drugs in general?
Yeah, in general, a package insert is basically a piece of paper or a document that's included inside of the container that the meds are shipped in. It carries with it details and information about the drug. For example, Tylenol would have a package insert, so when the hospital orders a bulk order of Tylenol, there's a package insert and it would say important considerations to consider. It would list anything that you need to be aware of, and it would list a myriad of side effects and things like that. So it was, if you didn't know anything about the drug, you could read that and kind of get a sense of what it was for and how it worked.
Does fentanyl have a package insert?
It should, yes.
And were you aware of it back then in 2016, 17, 18, those years? Had you read the package insert for fentanyl?
No.
Okay. What about benzodiazepines such as midazolam and or Ativan? Do they have package inserts?
Yes.
And were you familiar or had you read the package inserts for those benzodiazepines, midazolam and or Ativan?
I'm not sure.
Okay. Was your knowledge back then that they would have recommended dosages? Like you said, for acetaminophen, I think you said it had like a recommended dosage?
I don't think I said that.
Oh, okay, I'm sorry. Well, were you aware of whether, in general, package inserts have a recommended dosage for their use?
I think it depends, but back then I would not have known that.
Okay. Talk about the training you received regarding policies and procedures of Mount Carmel during your orientation and or afterwards.
So similar to my main orientation, it was incumbent upon the elder nurse who was training you to basically teach you where to go and where to find the policies. So it really depended on if the nurse you were learning from even knew where to find them. They were notoriously difficult to find. So there's the internet. Mount Carmel has an intranet, so it's their own like in-house internet. And you had to click, in my opinion, it was difficult to locate those policies and procedures. So they were not readily a part of my orientation process. And to be quite honest, I'm not sure. It would have taken a considerable amount of focus to figure out where to find them.
Were you ever made aware of any policies or procedures or order sets that were in the Mount Carmel policies and procedures for palliative extubations in 2016 to 2018?
I'm not sure.
Okay. At that time, were you aware of Mount Carmel's medication administration and self-administration guidelines procedures?
Is that the same thing as Lexicomp?
Lexicomp is part of that, yeah.
I was aware of Lexicomp.
Were you aware whether or not doses could be adjusted outside of those guidelines?
Yeah.
Are you aware of what needed to be done if those dosages were administered outside of the guidelines in that policy and procedure?
Can you be more specific?
Well, under what circumstances, if you're aware, could dosages of medicines be administered outside the guidelines for fentanyl?
Objection, foundation.
I'll permit the question.
At the time,
At the time.
I believe so, yes. And some of those things that would require them to be adjusted could be opioid tolerance, weight, age, any sort of factor that makes us different. I believe one of them is palliative care.
Were you aware of whether or not you needed to go outside of those guidelines? You would need literature, some sort of either learned article and or...
Objection.
I'll let him finish the question.
Sure.
Were you aware that one of those guideline deviation requirements was literature that needed to be cited to go outside those guidelines?
Aside from being leading, it's misleading too.
Okay, well, we're not doing closing argument. Let's relax.
I understand. Argumentative, and it does not apply to palliative withdrawal situations.
Okay. As the leading sustained. Rephrase.
Were you aware of what, if any, awareness did you have of literature requirements to go outside the guidelines?
I wasn't aware that I have to provide, I wouldn't even know who to give an article to. No, I was unaware.
What, if anything, were you aware of regarding special approval absent that literature from someone higher up in the chain of command?
Objection, asked and answered.
I don't think so. I'll permit it. Do you understand the question?
A little bit, no.
Absent literature
Okay.
that would support going outside the guidelines, were you aware of any requirement to get special approval from people higher up in your chain of command?
I would say that the people in my chain of command were involved in those practices. So I didn't seek any higher level charge nurse approval or something like that, because the charge nurses are the ones who trained me, and most are involved in this. So, no.
So you weren't aware of that special, of absent literature having to go off the chain of command?
Okay, overruled.
Correct.
He's just clearing up an issue. Go ahead.
Yeah.
All right. So to summarize and for transition, you received almost no training in...
Objection.
Well, I'll let him finish the question there. Go ahead.
For transition and for summary, as we go into the next topic, you received almost no training in college about the use of opioids and benzodiazepines beyond what you described. Is that correct?
Yeah.
You received no training about the use of benzodiazepines and narcotic medication during the preceptorship, the 8-week preceptorship you had, besides what you've described as being present when they were administered.
Asked and answered.
Well, he's in transition. I'll permit it.
Yes, I mean, I've given those medications to patients, but my understanding of them was limited.
And because of the difficulties in using the intranet,
Yes.
you had almost no knowledge or training regarding Mount Carmel's policies and procedures for use of those medications.
They were difficult
Permit
to,
it. It's transitional.
they were difficult.
Question, then we're moving on to the particulars of this case, Your Honor. And you've testified at a previous hearing that almost everything you knew in your first year of practice came from Dr. Husel.
Objection. This states the evidence, and this is
Okay.
the third transitional question.
Wow. There is no count, but that's beside the point. I'll permit the question.
Ask it again, please.
Almost everything you learned in your first year of practice at Mount Carmel was taught to you by Dr. Husel.
No, that wasn't the question. You previously testified to that. Is that correct?
If that's what I said, that's what I said.
Okay. So let's talk about December 5th, 2017.
Okay.
Do you recall a patient by the name of Danny Millett?
Yes.
All right. Looking back in your mind's eye, and you've had a chance to review the medical records, right?
Yes.
With that in your mind and looking back also, I want your independent recollection.
Okay.
Tell us about the first time you became aware of Danny Millett at Mount Carmel in December of 2017.
I was coming to work and I was responsible to take care of him.
All right. Describe his age, his condition, what you remember about him as you got to work, and what you did next.
So it was reported to me, he was an older guy, I believe he was in his 70s roughly. He had an extensive history of peripheral vascular disease, diabetes.
I'm
Yes.
going to stop you there. What is peripheral vascular disease? Your understanding of that back in 2007?
Objection. Is the counsel asking the jury this question?
Yeah, well, let's stay over here, but I'll permit the question.
You're asking me what my understanding back in 2017 was
Of peripheral artery disease.
of peripheral vascular disease?
Vascular disease, yes, thank you.
It's similar to peripheral arterial disease. So basically, I would have known this at the time as well, because of underlying factors, sometimes genetics, sometimes smoking, sometimes diabetes, all of which this gentleman did. It would cause your vessels in your hands and your legs and your body, everywhere in between, to become I'll say rigid, less pliable, so it's not able to adapt accordingly, and it can lead to issues if you think of a pipe, and I'm trying to get water through the pipe to an area. I'm trying to get blood from my heart to my foot, for example. If there's a kink in the pipe somewhere, or the pipe is smaller, or it's occluded or clotted, you're not going to get water to the end goal. So peripheral vascular disease and peripheral arterial disease would be the equivalent of not being able to get blood to certain areas of the body. And without blood and oxygen, importantly, to those areas of the body, you can have very bad issues.
Peripheral means like the in parts of your body, right? Is that what
No. No.
Okay.
Like it could be it could be systemic. I don't know why it's called peripheral, but there's, peripheral's relative.
Okay. Do you recall whether or not Mr. Millett had any recent amputations?
He did have an amputation of a toe,
Okay.
secondary to those things that I described: diabetes, smoking, peripheral vascular disease. But he also additionally had a procedure, I believe it was a bypass graft. So that's a little bit bigger of an issue. So when you're dealing with bypassing vessels, you're actually bypassing bigger vessels in the body to try to reestablish or maneuver around clotted or bad areas of vasculature.
Do you recall, you said you recall him being in his 70s. Do you recall what his height and weight was?
No.
Is there anything I could show you which would help refresh your recollection as to his height and weight?
Sure. Yes.
Would the medical records help you establish his
Height and weight?
height and weight?
Yeah. Yes.
It's my understanding the records are stipulated.
The records are stipulated, Your Honor.
Why don't you just ask them if the question then?
Okay. If the records indicate that he was 5 foot 8 inches and 140 pounds, does that help? Does that sound about right in your mind's eye looking back on it?
Yes.
Okay. And he has had this toe amputated. He's had a vascular bypass done on his leg. Were all of these things been made known to you as you come into work that day?
Yes.
Okay. And you're working the night shift in the ICU, right?
Yes.
All right. So looking back in your mind's eye, it's December of 2017. You walk in. We've heard about this handoff or huddle that you have with the previous care team.
Yeah, that's correct. The day shift nurse would give me report. This is the gentleman, this is why we're here and how we got to this point and what we're doing.
Okay. And did you do that with Mr. Millett?
Yes.
All right. And so in our timeline, this is about a year into your work.
Yeah, roughly, yes.
You've been working at Mount Carmel in the night shift for about a year, maybe a little more than it.
Correct.
Okay. And do you recall who the doctor was on shift that night?
It would be Dr. Husel.
All right. So what happens? What happens next? You walk into his room, I'm assuming, at some point?
Yeah, I walked into the room.
Tell the jury about the care. What are you doing? What are you looking at?
So I'm looking at everything. Obviously, I get in report that this gentleman is very sick. So he had this procedure, and he's back with complications secondary to some procedures. He has septic shock. So septic shock is a pretty bad bloodstream infection that can lead to some very bad outcomes. So I get in report that he's on vasopressors, Levophed, or another name is norepinephrine. And to me, that's significant right there. And I believe he's intubated at the time as well. So in my mind, at least the way that I process information, I hear about septic shock, which is potentially fatal. I hear about him requiring ventilatory support, so his lungs have failed. His kidney function has failed, as evidenced by his lab work. He's requiring adrenaline, basically. So like I always say, that when I think of vasopressors, that is the stuff that pumps through a mother's veins when she pulls cars off kids. That's adrenaline. This is noradrenaline. We're giving that in an IV, and I believe he had needed CPR at some point as well. So he's very, very sick. So yes, I enter the room knowing all of this. I check my drips. I check the patient. I see where we're at.
What happens next?
At some point throughout the stay, after my initial assessment, I made it part of my regular practice that when I have a super sick patient like that, I'm trying to check something every 10 minutes, every 15 minutes. I'm at least around the room, if not in the room at all times. So for this gentleman in particular, something that stands out is upon doing my assessment, part of it is to check pulses in the extremities. You check them in the neck, in the groin, in the feet, in the hands, etc. He lost pulses in his left limb, in his left lower limb. So that is significant to me because 1 minute he's, I'm gonna say relatively fine given all those things I described, and then 1 minute later we have this drastic change to where quite literally, going back to my example of trying to get the water somewhere or the blood somewhere, his leg will begin to rot now. So my initial, it's going without oxygen, the whole leg. So my initial reaction is to call the doctor. So I called Dr. Husel. Dr. Husel comes to the bedside. We assess the leg. We both cannot appreciate the presence of pulses. So we put what's called a bear hugger, which is a glorified name for a warmer, on the patient's leg to try to bring warmth, which brings heat, which brings blood to the area. And I believe a vascular surgery consult was placed. So this is indicating to me that while we were sick when I came in, we are beginning to get worse. We are starting to lose perfusion to limbs of the body.
All right, so you say you checked the left lower limb, so is the bottom part of his leg here?
Yeah, yes. The knee and below, yeah.
All right, so are you just doing it with your fingers, you do it with the stethoscope?
You could do it, so the way that I do it, I start by trying to touch them. I try to palpate them. Failure to do that, usually I like to think I'm pretty good at that. I was unable to. Sometimes the patient is swollen and you can't. So then my next intervention was to grab a Doppler. So a Doppler is basically like an ultrasound that you could listen to a baby's heartbeat with. You basically put gel and you just move this little dial around until you hear something.
How long is his left lower leg?
Yes.
And you can't hear anything.
Which is pretty much indicative that perfusion has been compromised.
Okay.
Okay, hold on. When you let him get his question out, a couple
sorry.
times you want to get out there, get that answer out there, we'll get to it.
Yes, sir.
But this poor lady's taking it down here, and we don't want her fingers to go up in smoke, so.
Yes, sir.
Mr. Zion?
Sorry.
So you said Dr. Husel came in, confirmed what you found. The vascular consult was done. What happens next?
It gets pretty vague from there, to be honest.
All right. Does this situation improve in your mind's eye as you look back on this, or does this situation continue to deteriorate as you look back on this?
As I look back, in my opinion, it continues to deteriorate. When you have a drastic change like that, it's important to let family know. It's important to keep them in the loop so they can make informed decisions about the goals of care. And I believe at some point shortly after that,
What about his condition? As you look back, having reviewed the medical records, he's intubated, you described his medical condition. What about his awareness? Do you recall if he was awake, if he's talking to people? Because you can be awake and ventilate, right?
you can.
Yeah. Was he awake?
No.
What about his level of consciousness that you recall, and based on the medical records?
He was fairly, I'm trying to use the right word. Let me think. He was out of it. That's what I'm going to say.
Okay. So you can't talk to him about what he wants next, right?
Correct.
So you talk to the family.
Yes. The primary decision maker, which is usually always family.
Okay. So did you participate in this conversation with the family?
Yes.
All right. Was Dr. Husel present, and did Dr. Husel, in your memory, participate in this discussion?
Always. It was customary in my practice, anytime that I was updating family with something significant, the doctor had to be present at the bedside.
Okay. Did you bring the family into bedside, or did you meet with them in a family room?
That I don't remember.
Okay.
In my practice, usually at the bedside, but I can't say specifically for this.
All right. What, if anything, do you remember about what you said to the family regarding Mr. Millett's condition and prognosis?
Yeah, I mean, I basically told them the same thing I told you. I would have said, we're having changes in his care here. We're giving this medication called adrenaline. It had not been explained that way to them before. I told them about this newfound change in his status, what we were trying to do to remedy that, and then I think we referenced some lab work. And I was a part of that, like pulling up on the computer and things of that nature.
Are you aware that in the medical records, the family had already agreed that afternoon to what's called a DNR-CCA?
Yeah, correct.
And what, in your mind, in your understanding back in 2017, DNR-CCA meant?
Yeah, so DNR-CCA, you have a full code, which is do all heroic measures, CPR, life support, intubation, all those things. Then you have a DNR-CCA, which means do everything that you can up until the point that the patient dies. And then if they do die, do nothing. Let that be the end. And then you have a DNR-CC. DNR-CC would be removal of heroic measures and allow sort of a natural passing without artificial means of life support. So he was a DNR-CCA, meaning that if he would lose pulses and die again, we would not implement life-saving interventions from that point to bring him back.
So what happened after this family meeting with you, Dr. Husel, and the representatives from the family there?
They agreed to change the code status to DNR-CC. So it was told to us, it was told to me that, passing naturally, pain-free, comfortable with the family at the bedside and not having tubes shoved in every body orifice was what the family wanted.
Okay. Do you recall what time of the shift this was for you that this decision was made?
I don't.
But working 7 to 7, this would have been in the evening hours or morning?
I mean, that
hours?
would be my normal hours, so that I don't really think of it like that.
Okay.
It's a 24-hour job.
Sure. But this is happening during the night shift at some point?
The change in care is correct.
All right. So what happens next after the family agrees to a DNR-CC?
Well, we talk a little bit about what that process is going to be like. It is discussed that, we're going to give pain medication. We're going to give medication to help promote comfort and only comfort. And we are going to remove and turn off these things that were keeping the patient alive. We discussed how it was impossible to determine how long, because most of the time people ask how long until, and it's, we say we don't know, we're turning off these medications, but we're going to give him pain medication to help make sure he's comfortable. We actually discussed like all of the stuff that we were going to do.
Did you talk to them about agonal breathing or the secretions that could build in his throat and what that meant as far as his discomfort and or anxiety and or pain?
Yes. Particularly the ones that I focused on was the rattling, secretions, vomiting, turning different colors. Sometimes you say agonal breathing, I think paradoxical breathing, meaning that when we breathe, your belly and your lungs tend to expand. Well, there's chances that one can go out and the other sucks in, so they work against each other. I've seen it, and it's it appears to be very uncomfortable.
So you prepare them for that. What did your training and experience tell you in 2017 about if that was actually painful or uncomfortable for the patient going through those things?
I don't think, personally, respectfully, I don't think any amount of education or training could prepare you for seeing something like that. So all training kind of goes out the window when you see somebody kind of like that. So I don't really have, I'm not sure what you're asking me.
Did you have any training regarding whether or not agonal breathing and or the secretions in the throat, it's also been called the death rattle, I think
Yeah.
they're called that, whether or not that was actually, I mean, disturbing for the family to watch, and you, apparently.
Yes.
What about, did you have any training regarding whether or not that was actually painful for the patient and or anxiety-inducing for the patient?
Specifically, secretions in the throat, and you say agonal breathing.
Agonal, paradoxal breathing, guppy breathing, all that?
I'm not sure if I ever read anything that said they were or were not painful.
Okay. Did you tell them the doses of pain medication? Did you get that specific? And the types? You said pain medication. Did you tell them the type of things you were going to get?
No, we didn't tell them the specific name of the pain meds that we were going to use. We just talked about that we're going to use a sedative and pain medication to promote comfort. And we talked about, we never discussed like, hey, we're going to give this much or something like that. But we said that we were going to give him an appropriate amount to make him comfortable so he could pass naturally with dignity.
Okay. As part of your review of Mr. Millett's chart and
Yeah.
part of your care earlier that evening, had you reviewed the previous pain medications and or benzodiazepines that he had received through the course of his hospital stay?
I knew that this gentleman, because in Mount Carmel system, you have, I'm trying to think what it's called. You would have had access to the previous hospital stay that he had when he had the surgery. And I knew that he got pain medication during then when he was shortly discharged. But I don't remember what I read about his pain medication up until that point. I can't remember.
All right, you're talking about his previous, when he had his toe amputated and the vascular bypass. That was a previous hospital stay.
It was, and you have access to those records as well.
Right.
And I would attempt to make it a point to read a little bit about that, only because that's why we're back again.
Okay. So he had not, during this particular hospital stay, had that pain medication, but in the from
Periphery.
December 5th, near that date, that had all happened to him, and then he went and came back. Is that what you're saying?
I believe so.
Okay. And you would have reviewed that?
Yeah. I would have particularly looked at like the OR records because of my interest in anesthesia, but also like, you know, if somebody is presenting back for an issue, you probably should go look at what the start to that issue was.
Okay. For this particular hospital stay, which, if the records say began on December 5th and ended on December 5th, had you had a chance to look at the medical records for that day he was in the hospital when he had come back?
I'm not sure. Wait, are you talking about the ones previous to that?
No, I'm talking about...
Oh, that day?
That day, because he was just there for a day, right?
Yeah, I'm not sure, only because he was pretty busy. I was doing something at least every 10 to 15 minutes, so I'm not sure. Can't answer that.
All right. Were you aware that he had only come to the ER on Tylenol?
Yes.
Okay. And that the only other pain medication that had been ordered for him was 2 milligrams of hydromorphine and 1 milligram of midazolam at 2139. Does that sound right?
Yes.
Oh, you know what? I don't know.
It-
I don't know if that's right, actually. I'm
Yeah,
trying to read my
can we
notes.
look? Is there any way you can bring it up?
Yeah.
And we could just,
Let's
get it
talk
down?
about Danny Millett's, if we may. Is that me? While I'm looking that up, did you assess his RAS score?
yes.
what do you recall about his RAS score? And just for the jury to remind them, what is RAS and how is it evaluated?
It's called a Richmond agitation score, maybe sedation scale or something like that. It's a measure of, it's one of the ways to measure somebody's demeanor. Yeah, and seeing as though he was kind of out of it, his RAS score that I scored him at was, I believe it was a -4 is what I gave him.
So if 1 or 0 is conscious and alert, and if you go to the positive, that's when people are getting angry and agitated,
Yes,
and then it goes backwards to -5,
I believe so, yes.
completely comatose, you rated him at a -4?
I think so, yes.
I apologize about the earlier medications.
Okay.
Were you aware that the only previous pain medications he had received during that, I mean, he was just there for the day, but he came in on Tylenol?
Yeah,
Okay. So, looking back in your mind and based on your review of the medical records, what was what, if any, order was given to you by Dr. Husel regarding pain medications to be given to Mr. Millett for purposes of this palliative extubation?
yeah, I received a verbal order for fentanyl and Versed, and I believe there was a Dilaudid attached to that as well. But I received that verbally from Dr. Husel.
What amount did you verbally receive an order for the fentanyl?
1,000 micrograms.
What amount did you receive a verbal order for the midazolam?
I know I looked at it. I don't want to say the incorrect number.
Sure.
Is it?
Showing you what I marked for identification purposes. And Judge, instead of going into since they're all coming in together, I'm just going to refer to these as States Exhibit 4, the medical administration records. Who's doing this? Would be the medication. I was just going to show them ours. That's just what I pulled out. Approach the witness, Your Honor.
You may.
Showing you the joint exhibit for medical records obtaining Millett, page entitled Medication Administration Record.
Thank you.
And then I'm going to show you 2 pages of this.
Okay. Thank you.
You could review that and look up once you've had a chance to review that.
Okay.
I'm sorry.
Okay, you're away from the mic. No, I'm just telling him he's away from the mic, so it might be difficult for the court reporter to hear you. Could you hear him okay?
Yes.
Okay.
Okay. I think I got it.
Okay. Having refreshed your memory, was 1,000 micrograms of fentanyl. What, if any, order did he verbally give you for midazolam?
Looks like 4
Okay. And in what method were these to be given to Mr. Millett?
through an IV.
Through an IV push or through an IV bolus? Or through an IV bag?
Push.
Okay. And describe what that means to you, your understanding of that in 2017.
Yeah, draw it up in a syringe and administer it through an IV.
Do you recall the unit dosage that fentanyl was available to you in the ICU from the Pyxis machine?
100 microgram vials, so 2 mLs, 50 micrograms each.
Okay, so how many vials did you have to get out of the fentanyl to get the 1,000?
10.
And do you recall the unit dose of midazolam that was available to you in the ICU Pyxis machine?
I believe 2. So it was
how
1 milligram per cc, 2 milligram vials.
So how many vials of midazolam did you have to get out?
2.
And then how did you prepare these doses to be able to give them through an IV push?
Took a needle and a syringe, I drew them up, put them into the patient.
Okay. And where would you have drawn these up?
In the room?
Was the family present when you were drawing these up?
I'm not sure. I always gave family the option to stay for that. I never told them they could leave. I would be very upfront. I'll draw them up in front of them. I'll draw them up if they don't want to see. Most of the time, in my experience, I believe families stepped out just because there is the potential when you pull an endotracheal tube or an ET tube, you can have a laryngospasm, a bronchospasm, people could vomit, they could cough, secretions could come out. It could be very distressing. So people had the option to stay if they wanted to see that. But I drew these medications up in the room.
Okay. Do you recall, you said you believe there was a hydromorphine dose also ordered, given to you verbally by Dr. Husel for this procedure?
Yes.
And do you recall the dose of hydromorphine that you were asked to give?
I believe 2 milligrams.
Okay. And was this also at the same time as the fentanyl and midazolam?
Yes.
Okay. And how was that to be given to Mr. Millett?
IV push.
All right. So, in summary, the verbal order was 1,000 mics of fentanyl, 4 milligrams of midazolam, 2 milligrams of hydromorphine.
Yes.
Is that all?
On that MAR, it looks as though there was another 50 micrograms of fentanyl as well. That I don't remember, but to my knowledge, it was 1,004 and 2.
Okay. Did you ask for clarification from Dr. Husel when he gave you this verbal order?
Yeah, in fact, I called pharmacy as well.
Okay. Why did you ask for clarification from Dr. Husel when he gave you this verbal order?
Twofold. The first being that I just wanted to know where his head was at. Although a mentor to me and established, that doesn't mean that he's beyond. Sometimes, I would not be afraid to question anybody. But I sought the clarification because I wanted to kind of get a sense of, hey, where's your head at? Why are we doing it this way? Things like that, because I just wanted to get on the same wavelength as him to help my understanding.
All right. And you called pharmacy?
I did.
Now, this was a verbal order. Does that mean, how did you have to withdraw it out of the Pyxis machine on a verbal order?
I would have had to go and log in and pull the medication myself.
Would this been on override?
Yeah, I overrode using my own independent nursing judgment, believed it to be an emergency, and I thought I was justified in overriding said medication.
Okay. And while we're on the topic, based on your training and experience in the ICU at Mount Carmel West, how common were overrides?
In my experience,
Yes.
everybody did them.
Okay. Was this standard operating procedure in the ICU at Mount Carmel West, based on your experience?
For the limited time that I was on days, yes, and when I worked night shift, yes.
Okay. But you called pharmacy.
I did.
Why did you call pharmacy?
I called Greg White, and I told Greg White that, hey, we're going to do a palliative extubation on this patient. These are the medications he wants to give. I don't believe I had ever given that level of dosing before. So, and I just wanted to just tell pharmacy, hey, this is what we're going to be doing and this is the meds I'm going to be using. And then I told Greg that he could come up to the bedside and talk with us if he wanted.
What happened next?
So all I know is that Greg came onto the unit. I saw Greg present on the unit. I do not know if a conversation happened. I do not know anything after that other than I found Husel shortly thereafter. I said, hey, you know, are we good to go? Is this still what the goals of care are? And the answer was yes.
What happened next?
I gave the medication.
What happened next?
The patient's family was asked to be back patient's family, I don't remember if they were in the room or out of the room, I'm not sure, but patient's family spent time with the patient. Him being Dr. Husel and I sat nearby at the nurse's station to where we could be there if family needed anything.
All right. Now, we've heard from previous people that have been through this as professionals at Mount Carmel that you disconnect or black out the monitors in the room.
Yeah, it's basically a way to it's not shutting off, it is a way to pause all of the alarms in the room so it's not distressing to the family if they're praying or something like that. So they don't get to see anything, and that's only because we want them spending those last moments with their loved one. We don't want them watching the monitor. There are nurses who didn't, you didn't have to do that. That was a courtesy that we provided because we wanted that to be about their interaction and less about, okay, oh, it's flatlined, the patient is now passed. So we were able to see those outside of the unit, or not outside of the unit, outside the room, without the family having to hear or see all of that as well.
At that nurse's station, you've got a monitor up that's showing what's going on.
Yeah, there was a number of them around the unit.
Okay. So what happens next?
The patient died.
Do you recall how quickly the patient died or how long the patient lasted?
No.
Could you estimate in your mind how long it was?
Minutes.
Okay. What happens next?
We let the family spend time with their loved one. Some of them, do more prayers. Some of them do that. What happened next is the family said their goodbyes. I went in. I pulled out the remaining tubes and drains in the patient. I washed the patient. I cleaned the patient. I tried to give the patient the care that he deserved, and then I put him in a body bag and took him to the morgue.
Okay.
And I believe I enlisted the help of some of my other friends, co-workers as well, to help with that, just because it's a grown gentleman.
Sure. And before we move on from Mr. Millett, did you recall reviewing the pain score charting that he received during his stay at Mount Carmel on December 5th?
Yeah, I reviewed that.
And what were the previous pain scores prior to your entry as you gave the medicine?
0, or not entered.
All right. And what pain score, if any, did you give Mr. Millett as you administered those medications?
I believe I gave him a 10,
Okay.
and that is incorrect. And that is incorrect because I used something called a CPOT score. CPOT is the observational scale that you use when a patient is unable to communicate themselves. That scale goes from a 0 to an 8, whereas any other scale usually goes from 0 to 10. So I scored that trying to indicate the maximum amount of pain, and I'm not sure why I settled on 10. That could have just been a lapse in judgment on my practice.
What did you, looking back, using the CPOT scale, if you had that in your mind, CPOT only goes from 0 to 8, what would you have ranked Mr. Millett's pain at the time that you administered those pain medications?
Consistent with my charting, I would have given him an 8.
Okay, and why would you have given him an 8?
So I would have given him an 8 for a myriad of reasons. The first is what's going on with him. So he's had CPR. He has a tube in his mouth. He has, I believe, an A-line, so he had a tube in his groin or wrist. I don't remember which. He has a tube shoved in his penis. He has a tube that is in his neck. He has lactic acidosis. Lactic acidosis is something that if you go on a long run or you do an extensive workout, that pain you feel is because you restricted blood flow to your muscles, to your chest, if you were benching or something like that. He has a he has a lactic acidosis level, so that could, in my opinion, be painful. So I'm scoring it based on, and he's had a surgical procedure. I've scored that based on what is going on with him. His limb is now potentially rotting off, and I'm also anticipating a good deal of pain.
Okay, let's break that down a little bit.
Okay.
Just to revisit that, you said he had a tube shoved in his penis.
Yep.
Why did he have that?
It's a urinary catheter. When you are intubated and on life support, we like to measure urinary output because that's a good indication of how the kidneys are working. In this gentleman's case, Foley catheter, a urinary catheter was placed. His lab levels, his creatinine is a measure of kidney function, is elevated. Urine output is low. His kidneys have failed or are in the process of failing.
Yeah. But that term, quote, tube jammed into penis, that's not how you describe a Foley catheter, is it?
It depends. I mean, that was how it was put to the family.
By whom?
Dr. Husel said that.
Right. Those are Dr. Husel's words.
Yeah, and I seconded that information.
When you charted the previous 0 or didn't chart pain at all, while he is under your care as you came on the ship, did you give him any pain medication for any of the pain you felt he was in at that point?
I don't understand the question. I'm sorry.
Well, you say that it's not just based on anticipation of pulling the tube out and letting the dying process happen. Mm-hmm. You're saying all these other things that have happened to him.
Okay.
The Foley catheter, the arterial line, the chest compressions.
Right.
And when you say surgery, this isn't from December 5th. This is from a week or two before.
Objection leading.
Okay, I'm gonna let him clean it up. Do you understand the question?
I do.
Okay.
But in regards to the specific point about surgery, there's still surgical incisions.
Okay.
And those things tend to hurt afterward. But to that point, to your question, I don't think I gave him any pain medicine leading up to that point.
Okay. And so it wasn't just those things. You were also anticipating that this process is painful and unpleasant of dying, the process of dying.
Yes, dying in that way. You know, this is, in my opinion, I always made it a point, this is atypical from regular palliative care, in my opinion. Palliative care is somebody like a loved one who gradually declines over the course of days to weeks to whatever, right? It's more of like a plane landing, a gradual descent into death, whereas I liken what I believe I was going through and what the patient was going through to a helicopter. You know, he came in, admitted on the 5th, and died on the 5th. This wasn't a gradual decline into death. This was rapid clinical decompensation.
And he did die quickly after the tube had been pulled out and those medications.
And the vasopressors were stopped. Those tend to be they don't last very long once they're turned off or stopped.
All right. Let's move on to, Judge, it's 10:15. I'm going to transition to the next patient. Are we still good? I mean, I'm just letting you know I have a transition here, but I can keep going just fine.
Why don't we go till 10:30 and then we'll take a break?
Yes, sir. Let's go to May 28th of 2018. So that was in December of 17. So we are approximately 6+ months later.
That's correct.
All right. And so now your experience as an ICU nurse is night shift, Mount Carmel, 1.5 years plus at this point?
That's accurate.
All right. Have you been promoted to charge nurse at this point?
No, I never wanted to be a charge nurse.
Okay. Are you precepting anybody at this point?
I don't believe so, no.
All right. So, James Allen,
Okay.
tell us about coming into work, the first time you remember seeing James Allen.
Yeah, so James Allen, I came on to work. James Allen was placed in the CVICU. Mount Carmel had a mixed ICU, but there was another part just across the hall that had about 6 beds maybe where you could have an ICU patient. So he was in the cardiovascular ICU, although he was there for a medical-based issue. We used that because that's where the open room was. But yeah, I would have gotten a report much similar to how I described Mr. Milletti's case. So for Mr. Allen, I got report. It had been reported to me that he was admitted. He had an ejection. So one of the things that stood out up front is in his past medical history is something called an echocardiogram. That is a way to assess how well the heart functions as a pump. It fills, it pumps, it fills, it pumps. Every time that the heart pumps, a certain amount, a certain percentage of what it's filled with comes out. Normally, usually, a normal value is 60%, 65% maybe. His was 10 to 20%. So he's a very sick patient with COPD, and other coronary artery disease, coronary artery stenosis, vasculopath, like a peripheral vascular disease presentation. So that's the background that I get. I learned that he is admitted because he came in for a procedure. He was in endoscopy, so they took a scope down and they placed a stent in the bile duct to remove gallbladder sludge. I believe he had that twice. There was a complication which left him in the ICU. In the ICU, he was septic from that. And he was on vasopressors and undergoing care. He actually recovered from that and was transferred off of the ICU to a different part of the hospital. I don't remember where. Where I get involved is learning that, okay, secondary to all this information, he comes back to the ICU after rapid response took care of him, after having some trouble getting in contact with certain doctors. He was decompensating and came back to the ICU in what we call AFib with RVR, which is atrial fibrillation with rapid ventricular rate, which is a body's basically fight or flight mechanism trying to keep him alive because he's beginning to go septic. He's beginning to be infected. And I'm losing track right now, but there is a chance that he lost pulses. I don't remember if he coded or not, but I know that it wouldn't surprise me if you told me he did.
Okay, if the medical records reflect that he did have a code while he was there,
Yeah.
Would that confirm that that memory in your mind?
Yes.
Okay. Do you recall his age?
I believe he was in the 80s.
Yeah. Do you recall his weight and height?
He was a bigger guy, bigger than the first gentleman that we discussed. I believe he would be classified as being obese.
If the medical records reflect that he was 6 foot and about 188 pounds, would that be obese in your mind?
It depends. If you're using a BMI scale, it's very possible. But BMI would say that we're all obese, so.
All right. Well, if the medical records say he was 6 foot and 188 pounds, would that sound right in your memory?
Sure.
Okay. So he's a very sick gentleman. That's the report you get.
And I believe he's on vasopressors as well, and he's intubated. He, in the rapid response note that I was gotten report, he vomited, and he vomited what appeared to be blood. And the blood went into his lungs. So this is what I say, like if you've ever drank water and something's gone down the wrong pipe and you cough. Well, in this instance, blood from wherever, a GI bleed or something, gastrointestinal bleed, must have went down the wrong pipe and led him to a profound pneumonia. So that pneumonia progresses to lung destruction in the form of acute respiratory distress syndrome called ARDS or ARDS. So he is beyond sick as an ICU nurse.
And when it goes down the wrong tube like that, that's called aspirating?
Yeah, aspiration, yes.
All right. So had you treated him prior to May 28th?
I'm not sure.
Were you aware that he came in on May 24th? Does that sound right?
Yeah, it sounds right.
So 4-day hospital stay, man in his 80s, 6 foot, 188 pounds, all those problems you described. And you recall that part of your understanding of his condition was this endoscope to get rid of the sludge in his, and a stent being placed, but that having to be done a second time.
Yeah, there was a complication.
And it's thereafter that he's transferred up there because he has this episode of throwing up blood and aspiration.
Well, kind of, because not stenting that area, not opening up that area was what was giving him symptoms to have the need for said procedure. So you can go septic from that. So his first initial admission to the ICU, he was for septic shock secondary to the complications of his ERCP or his endoscopic procedure, recovered, had a setback, maybe the infection worsened, the aspiration infection took over, and then he came back to the ICU.
Okay. And when he came back to the ICU, do you recall whether or not he was intubated at that point?
Yeah, he coded, yeah. He would have had most of the things that the first patient we talked about. Usually that is a routine procedure to give people a catheter, an A-line, a central line, which is an IV typically in the neck or groin, and things of that nature. Fully catheter.
All right. So this is how he presents to you on May 28th.
And that's what I get, yeah, that's how he looks, and then of course that's what I get in report.
All right. So you're getting on your shift, you've got the report, what happens next? Do you know his code status?
I don't remember what his code status was.
If the medical record...
I'll permit the question, but you went from one question and transitioned to another, so you had a hanging question there. But he answered your tail end of it. Let's move on.
Is there anything I could show you which would refresh your recollection as to his code status?
I'm sure there is, yeah.
All right. Well, let's move on while I'm looking for that. So he is not, though, at this point in your memory, somebody that you're pulling the tube at as you come onto work. Is that right?
I don't understand.
He's not DNRCC.
I don't think so, but I would like to see to be sure. One thing that stood out to me, aside from his vasopressors, the adrenaline that he was getting, was his ventilatory settings. So he was, in a typical ARDS or acute respiratory distress fashion, he was requiring even more support than what usually goes on.
Okay.
So I do anesthesia, right? So most people who get intubated for procedures get, I'm sorry to go on a tangent, but I think it's important.
Well, we need to make sure that what you're testifying to is based on your understanding at the time.
Oh, 100% I would know this, because this is something that I learned after, I said like about a year to a year and a half is when I felt comfortable, so I would have known this.
Okay.
Everybody in this room is breathing 21% oxygen. So out of all the gas and crap that makes up the air, 21% of it is oxygen. When you typically intubate a patient, or I intubate a patient for surgery, or even back then if you had to go on the ventilator for a couple days, you would usually get about 40% oxygen, which is about double, and 5 of pressure, otherwise known as PEEP. It's the amount of pressure in your lungs to keep them inflated. This gentleman was on 100% FiO2, so 5 times the maximum amount of oxygen we can give, and his pressure, which is normally 4 to 5, was 12. So just to keep his lungs inflated and pressurize air through was a chore in and of itself.
But you're able to do that, right?
Yeah.
All right. What about the pain that you're observing as you're treating him?
I'm not sure.
Do you recall him being in a lot of pain when you're treating him? He's on a lot of life support.
Yeah.
Tell us about what you recall, if anything, regarding the amount of pain he's in.
I'm not sure. I know that he took pain medication at home, but I'm not sure if I independently gave him a dose of medication.
Okay. So of all the things that you're treating him for, as he's your patient that night, the ventilator settings that you've described, the myriad of medical conditions that he has and apparently is declining, pain is not one of those things that you recall having to treat him for.
Not that I recall.
Okay.
There was also, similar to the first patient, he also had an issue where he began to lose perfusion to his limbs. I believe that was also a leg. And much similar to the first, Dr. Husel called to the bedside and a vascular consult was placed. I'm sorry.
All right. Did that vascular consult happen to your memory?
I don't know. I don't think so.
All right.
I would imagine it did not.
Do you recall if this patient was on paralytics or not?
I'm not sure.
All right. Why would you give a patient on a ventilator paralytics?
It depends. The patients can overbreathe a vent. A vent can function in a way where it is going to deliver a set amount of air or oxygen every so often. You specify how often, and it's going to deliver that no matter what. Now you can overbreathe that vent, and you can do what's called fight the vent. So as the vent is pushing air in, you can be trying to exhale, and it can lead to basically issues where the patient is fighting the vent. So you could put somebody on a paralytic medication to take away that ability so you can let the ventilator do its role.
Judge, I'm going to object. Relevance, this patient wasn't given paralytics.
Okay, I'll let it stand as it is. I'll note the objection overruled.
Thank you. May I approach the witness?
You may.
Referring to joint exhibit. What joint exhibit are we on here, please? Mr. Allen is 8, right? Joint exhibit 8. Joint exhibit 8, showing the witness a progress note from that date regarding his code status. If you could review that progress note. Mr. Diemer, does that help refresh your memory?
Yes. I mean, I don't know. I'm trying to, maybe you can help me. How can I figure out when this,
Okay,
what's the
why don't we
date?
take a recess at this point in time, because it's time for a break. Okay, ladies and gentlemen, remember the admonition, 15 minutes. We'll get started at 15 till. Have a wonderful break. Have a good break, guys. Okay. Sir, you're under oath and you're also on the stand right now. We're going to take 15 minutes. Relax. You can't talk about your testimony. You can answer factual questions for them. But if anybody asks you how you're testifying or why you're testifying a certain way, it's improper.
Okay, yeah, I won't say anything.
Go ahead and relax and get off.
That this was court and then later that evening at 11. So I was trying to establish, and he just can't remember, so I was just trying to refresh his memory.
Mr. Zion, anything for the record?
You want me present to?
But we'll figure it out.
For the record, anything?
Not from the record, Your
Mr. Baez?
No, sir.
Okay, you were talking into the jury, let's avoid it,
Yes, sir.
okay? And
Yes,
I
sir.
understand handling the records over here that you're doing that, but when you get away from the mic, it's tough to pick you up.
Yes, sir.
Just to let you know. Okay, we're on break.
I'm trying to figure out when this note was in the record.
Ron!
Doesn't it feel about take me 15 minutes? Sometimes I like that. I know. I do too. You worry. I worry.
Yeah.
No, I don't.
What's around it, if we can figure out when that note was. 'Cause it doesn't appear to.
I think it's at the top.
I know, so but I look at the next page and it's not on there. So
There's we saw it advertised as one of the pictures of Deemer's events. And it's like a trip to a bunch of.
Yeah, Normandy and things like that.
Something he saw.
Normandy's actually a beautiful place.
Friends of ours went, was it the 70th anniversary of 2019?
They went.
That was in 2018, wasn't it? 43?
Whatever year.
I have.
It was.
Might be 44.
I can't do the math at all. Thank you.
That was it.
Okay, yeah, very good. I had a big fail this weekend.
What?
Parenting fail.
What'd you do? Let me turn off this mic.
We doing okay? Oh, these are my notes. Mm-hmm. Yeah, he's fine. I think the jury's getting. I'm sorry, what's that? No. I was going to get that. I was going to get more. You actually have it. Excellent. Maybe we can avoid runs.
You can be seated. Mrs. Zion, you ready to proceed? You're still under oath. Okay, yeah, have a seat and relax.
Showing you again the same exhibit from before for purposes of refreshing memory and also the order that we showed you here. I think I had a question about where this note came from. This is actually sort of that shoot.
Oh, thank you. This would help me, yes. Okay.
And then also looking at an order form from the same exhibit that has your name on it. Does that help you recall what his status was when you saw him that night?
Okay. Yes.
Is your memory refreshed now as to his status regarding his the level of care he and or his family wanted him to receive when you came on shift that night?
Full resuscitation.
Okay. Now you've gone through some of the issues that he's having. At some point, is there a discussion with the family about changing that full resuscitation status?
There is.
Tell us about, in your mind's eye, looking back on this, how that occurred. Who came to who? What was discussed?
So I was sitting at the nurse's station in the CVICU. It's more of an open nurse's station in comparison to the other side. I was approached by a family member who called me and approached me and voiced their desire to withdraw care.
What happened next?
I told them, I said, I understand. Well, this was also after we presented those things that I discussed earlier about his change with the leg and everything as well. They approached me. I said, okay, I'm understanding what you're saying, but I can't do anything. The doctor has to be at the bedside to hear this. So I called Dr. Husel. Dr. Husel came to the bedside, and then they basically voiced the same desire to stop all treatment.
All right. At this point, is your patient stable?
To me, no.
Is there anything rapidly declining about his condition at this point besides what you've described?
I've described everything that I can think of.
Okay. Do you recall what time of the evening this would have been?
9, maybe, approximately 9 o'clock, a couple hours into the shift.
If the note says this conversation occurred at 11 p.m. In the medical records, would that fit with your memory?
Yeah, that would be more accurate, yeah.
Okay. So once the decision is made by the family to withdraw all care, well, that's
DNRCC.
DNRCC, to withdraw life support care. Let's phrase it that way.
Yes.
What, if anything, is given to you as orders regarding this procedure?
Verbal orders for medications.
Okay. By whom?
Dr. Husel.
And what were the verbal orders for the medications that were given to you?
The numbers are, once again, like the first, they're blurring together, but I know it was 1,000 micrograms of fentanyl was one of them, and there was some dosage of midazolam or Versed.
Is there anything I could show you which would help refresh your recollection as to the amount of medication that was ordered?
Yes.
Before we get into that, so it's 1,000 micrograms of fentanyl. Were you aware at this point of any pain medication that he had received previous to this order of 1,000 micrograms of fentanyl?
Not that I don't remember.
Okay. Had you been actively treating your patient for pain throughout the evening?
I don't believe that I actually dosed him with any pain medication that evening until the withdrawal of care.
If the records were to reflect that he had been receiving a drip of 25 micrograms of fentanyl infusion throughout his stay, would that help refresh your memory?
Yeah, it would.
And what's the difference, based on your training and experience back then, between a drip and an IV?
Objection, Judge.
For the reasons we've already discussed, overruled.
No, I'm talking about counsel.
Okay. Let's stay back on over. Go ahead and finish your question.
What's the difference between an IVV push and a drip?
It's just the method of administration. One is continuous, the other is, like you said, it's a bolus, it is an upfront, one-time dose.
And if it's gauged at 25 micrograms an hour, how much medicine is that person receiving in 1 hour?
25 micrograms an hour.
Showing you, for purposes of refreshing recollection, the medical administration records with James Allen.
Yeah.
Approach the witness, Your
You
Honor.
may.
Thank you. Oh, okay. Okay. Yes, I'm refreshed.
Okay, all right. So in addition to the 1,000 micrograms of fentanyl IV push, what, if any, benzodiazepine and the amount and manner did Dr. Husel order?
6 milligrams of Versed to be given IV push.
All right. And was this to be given at the same time?
Yes.
And you said these were verbal orders?
Yes.
All right. At this point, did you ask for clarification from Dr. Husel?
Yes.
And once again, why are you asking for clarification?
Similar to the first gentleman that we described, I wanted to just kind of understand his rationale. I need to hear, just like with any, I mean, it's not really seeking it because of the specific medication. Anytime that there's a new order placed, I want some sort of contextual reason as to why it's being placed. So this was me being like, hey, I know we're doing this for palliative extubation. Why are we settling on this dose? Secondary to the fact that this is a different dose than I had given the previous gentleman. So why is there this variation here?
Your training and experience at the time, were you aware of any synergistic effect between between benzodiazepines and opioids when administered at the same time?
Yes, I am aware of the synergistic effect between opioids and benzodiazepines.
Were you aware of that back in 2018?
Yes.
You recall testifying at a previous hearing that you did not have training on that and were not aware?
Well, I did not have any formal training on it, but that would have been something that was vaguely covered in one of those daily pharmacology things. To expand a little further, I would have heard the term synergistic effect before, but I had no previous experience from which to pull to say, oh, that's what the synergistic effect is. It had never clinically presented itself to me. I wouldn't even know what it looked like. But I knew that it's this esoteric thing that exists.
esoteric. Can you define that for us, please?
Oh, I don't know, just like theoretical thing that exists. Maybe that's the wrong word, but to me, that's how I meant it.
Theoretical.
Yeah, like, it had been touched on, but I have no idea what that appears like in practice.
Okay, thank you. So when you go to the Pyxis, how do you have to get these out?
Entering and pulling them, and since it's verbal, it would have been an override.
And same procedure as before regarding getting the multiple vials and having to put them into a single, well, two, one for the midazolam, one for the fentanyl.
Yeah, I'm not sure how many syringes I used, but it would have been the same process. I would have gone independently, overrode the medications, took them to the room, drew them up, and a syringe administered to the patient.
Okay. And so do you administer these before pulling out the endotracheal tube or after?
I don't remember. My assumption, I don't want to assume, so I don't remember.
Well, do you recall what your practice would have been?
It would have been to give them before.
All right. And why are you giving these doses, why are you giving him fentanyl and midazolam in your mind at this point?
Why are we doing it?
Why are you doing it? In your mind, why are you doing this?
Yeah, much similar to the first gentleman. This guy has a very bad lung injury. He's receiving positive pressure ventilation through an endotracheal tube. His ribs are probably sore from the CPR. He has lost pulses to that lower extremity. His lactic acid level is 20, which for reference, normal is 0 to 1. His is 20. And he has, as before, a Foley catheter and various other medical instruments in his body. And he has been receiving, he would have been on pain medication.
Okay. At that drip of 25 micrograms an hour?
Yeah.
Do you recall charting any of those, did you recall observing either in your mind or charting any active symptoms of pain during the course of the evening when you took care of them?
I don't recall.
Okay. If I were to show you the pain score charts, would that help refresh your recollection as to whether you charted any pain medication or pain score for him?
It would, and I guess I just want to be more, you're asking previous to the extubation or just throughout my care for him?
Yeah, previous.
Oh, yeah, I'm not sure. I would need to see that document.
Okay. Do you recall documenting any RAS scores for this gentleman?
Yes.
And do you recall what his RAS score would have been?
I believe I put it either a -3 or a -4. I believe someplace I indicate that he was withdrawing and grimacing.
Okay. But -3 and -4, what would that be regarding his level of consciousness?
He wouldn't be doing, he'd be out of it.
Okay. What about the CAM score? What's that? Do you recall what that is?
I remember it, and I'm confident enough, I believe, to say that that's like a CAM ICU. I think we did that for screening for delirium. I could be wrong, but that's seemingly is what that is to me.
May I approach the witness, Your Honor, for
You may.
purposes of impression, showing you the direct flow charting sheets from James Allen's medical records?
Thank you.
Read those, please.
Yeah, thanks. think that's a double.
Oh, okay.
Is this a repeat? Okay.
Sir, does that help refresh your recollection as to whether or not you charted any pain scores for Mr. Allen previous to his extubation?
Yes,
And did you chart any pain scores previous to his extubation?
I did.
And what were his pain scores?
I charted a 0.
And why did you chart them at 0?
I must not have appreciated any pain on that assessment.
Okay. So after you take out, either before or after you give him the medicine, and it would have been your practice to give it beforehand, you recall, do you recall if the family was in the room with you when this was going on?
I don't.
What happens next? What's the next thing you recall happening?
Much similar to the first gentleman, I would have exited the room, allowed them to stay, allowed them to take whatever time they needed. Was at the nurse's station, and then eventually, once the patient passed, the family alerted me that the patient had passed, or at least I went in once the flatlined, and we kind of came to the consensus that we believed the patient had passed, and therefore I called Dr. Husel to come to the bedside to pronounce.
Okay. And why are you calling Dr. Husel to pronounce if you can see that he's flatlined and no longer alive?
I do believe that there's like a physician obligation to have to pronounce. I can't, that's out of my scope of practice to pronounce death.
All right, so it would have been Dr. Husel, that would have been one of the things he had to have done because you don't have that authority.
Yes.
Okay. When you or others in the ICU document things, do you always do it in real time?
No.
Why not?
Sometimes you're very busy. You can take care of patients that are so busy to where sometimes you need multiple nurses to help take care of a patient. Sometimes you can't even use the bathroom. It's very busy. So my number one priority is to be there for the patient first. And sometimes that leads you to do several interventions. And then when you finally, if you get a chance to sit down, you go back and try to chart what you did to the best of your recollection. I would rather treat the patient then chart instead of charting and leave the patient to go through whatever it is they're going through.
Sure, makes sense. So when is back charting the right term?
Sure.
How would you describe it?
I'm charting to the best of my recollection if I'm not able to do it in real time. So we can use back charting, that would be fine.
Okay, and so would the times of things that happened when you were back charting be exact, or would they be to the best of your recollection?
They would be approximate to my recollection.
All right. Let's talk about December 5th, no. Sorry. Let's talk about October 24th of 2018. James Timmons. Do you remember this patient, sir?
Yes.
All right. So October 24th of 2018, how long have you now been at the ICU?
Over 2 years, 2.5 maybe, give or take.
Experience-wise, how are you experience-wise compared to many of your coworkers at this point?
Objection.
I'll permit it.
While still new, I had been seeking, I believe to try to gain entrance into anesthesia school. So I was going a little bit more in depth to sort of how things worked and things of that nature. So as I did that, they started to trust me with sicker patients. So I think I was respected on the unit. I by no means knew everything, but they began to trust me to teach new graduates.
And were you so doing back on October 24th of 2018?
That is correct. I was precepting a new nurse named Emma.
All right. You come on to shift October 24th, 2018. What, if anything, do you recall about James Timmons? What's presented to you in the huddle?
So I actually recall, I think, a lot. So I walked in, I came in the ICU back entrance. Mr. Timmons was in bed 4 in the ICU. And as I walked into the break room, which is where we got our handoff reports, coworker that I was walking in with, wow, that looks like a really rough night. Like, that seems like a labor-intensive night. So after about 5-10 minutes, we did our handoff and we got our assignments. I was told that I was going to be precepting Emma. So we were going to function as one nurse for the care of that patient. So I was assigned Mr. Timmons with Emma, and my first interaction, he was in bed 4, so we stopped. Like, after they told us we had bed 4, we left because we knew, okay, there's a crash cart outside the room. This is serious. We don't need to hear what's going on with patients that we need to get there now. So we went to that patient, and as it turns out, he was being taken care of by a nurse who was also precepting somebody. So the exchange of report was fractured a little bit because it was 2 new nurses trying to kind of get their wheels and get on course. But I'm kind of supervising that. While during report, because it went a little bit longer than usual reports take, and that's okay, he rapidly clinically decompensated. So as we're talking, I watched him on the monitor drop his pressures into, I believe, the 60s. Knowing, coupled just with what I'm seeing a crash cart, yeah, this is not good. So I told Emma, I said, I told the day shift nurse, stop giving report, go get Husel now. So she scurried off, got the doctor. He came to the bedside, he was out on the unit, and we instantly initiated several life-saving issues. And this is really without knowing why we were there yet. So we gave several medications that included sodium bicarbonate. We pushed that through an IV. That is trying to raise his blood pH. And this is all verbally. Dr. Husel's giving this to me verbally, so I am overriding these medications. We give sodium bicarbonate. We do a stat lab level check, and his potassium level is elevated, which places you at risk for cardiac arrest. So we did what's called the potassium cocktail, or the K cocktail, which is a way to artificially lower potassium levels to stop your heart from having a funky rhythm. So we gave calcium gluconate to stabilize the heart. We gave dextrose to raise blood sugar, and then we gave insulin to drive the potassium into the cells to lower that. We then broadened out antibiotics, and what we mean by that, or what I was led to believe that meant, is this was signs and symptoms of like progressively worsening septic shock. So instead of doing like specific antibiotics, just pick the 2 classes of antibiotics that cover everything. So he told us to do that, and then we ordered what's called a stress dose hydrocortisone. And I interpret that at the time to mean that whenever like some degree of stress on the body is good, it helps us mount a fight. So sometimes these patients who are in the ICU need medications, they need the steroids delivered because it helps them mount that ability to fight. It actually enhances the ability of the vasopressors, which he was on, the adrenaline, if you will, to work better. So all that occurred in the first 15 minutes of our shift. And that is fairly atypical. Like, people decompensate, but that may have been the first or second time that ever happened to me while talking. All right, I don't even know really why we're here, but we need to do something. And Dr. Husel was around the corner getting a report from the residents on the day shift. So me, him, and Emma are basically treating this patient having not even received a full what happened for today. So that's the start of the day.
What happens next?
So he continues to have these episodes throughout the night. His brother is called to the bedside. I'm not sure if I called him or if he was there, but Lynn was there, and we updated him with the situation. You know, he is very unstable to the point where he's swinging one way to the other pretty quickly, minutes really. And I said, you know, we kind of handled that part, but like we're by no means out of the woods. I remember telling him that. And he said, oh, well, it looks like we're going to make it through the night. And I said, no, we will not. I didn't say no, we will not. I said, no, I'm not even thinking about it like that. I'm trying to make it through the next 30 minutes to 1 hour.
I'm going to stop you there.
Yes.
Lynn, when you say Lynn, who are you referring to?
I believe that's the patient's brother.
Okay. What happened next?
So Lynn left, despite us telling him he probably shouldn't. Throughout the night, we were going up on the vasopressors and trying to treat all of his issues secondary to why he presented. I ended up calling Lynn back, and Lynn came, and we updated him with, we had one more episode of sort of that dramatic sort way. He wouldn't want to live like this. I don't want any of this SHIT. Take it away. And then much similar to the other two patients that I previously discussed, said, I get what you're saying, but I got to call the doctor. The doctor was called. Husel came to the bedside, and we went from there.
When you say you went from there, what happened next?
So we discussed the goals of care, which was now Lynn's, his brother's willingness to withdraw and make a DNRCC. We told him, and we did have this conversation, that we were going to give him pain medications to let him pass peacefully, naturally, pain-free. And we did talk to Lynn about his drug use and his history. We said that he's received a lot of medications throughout the stay. He's coded many times throughout the stay. We didn't discuss the use of fentanyl per se, but we said we were going to have to use like higher doses because of his tolerance. And then we basically told Lynn, and I remember telling Lynn this myself, I said, we're here to do whatever you tell us to do. If you want to keep going, we go. If you don't, we can stop this. It was, you know, and then the decision was made to withdraw care, and then, yeah.
Do you recall what time of the evening this would have been in? Or
It was early morning, so after midnight.
if the records reflect, or is a note signed by Dr. Husel at 3:27 a.m., does that sound right?
Yeah, that sounds appropriate.
All right, so this is on October 24th. So what happens next?
So I think it's important to note here that Emma's great, but Emma also was very limited because she was new. So I was very busy with Mr. Timmons. So there was another nurse that was helping me throughout the night. So really we had like 3 nurses, but Emma was just learning. So it was me and a nurse named Earl. He would pop periodically in throughout the night and help me do all the cares for the patient. Sometimes he would help intervene. He was always on nearby because we knew that at any minute this guy could go the opposite way. So after the discussion with the family stepped out for that one. They went with the palliative care, or not the palliative care, the chaplain, which is like the I don't really know what the chaplain does other than just kind of help, like a liaison between goals of care. They went with the chaplain to talk, maybe do a prayer, I'm not sure. In that time, Husel was at the seek clarification as to why we were doing that dose. I believe it was either Earl or Emma who pulled those drugs for me. They came back, they handed me the drugs, I had already received confirmation that my clarifying questions were answered by Dr. Husel. I drew up the medications and gave them to the patient. Exited the room, all of us exited the room. Lynn came back into the room. He was spending time with his loved one. Dr. Husel and I were sitting right across from bed 4. There was a nurse's station. We sat right there. About 5 minutes later, the brother opened up the door, not the door, pulled the curtain rather, because we had the curtain pulled. And he said, "Help, help, somebody come quick, he's in pain, somebody do something." From where I got up, I went into the room, Husel followed behind, and what I saw was not great. He was kind of grayish blue, more so gray. He had kind of like foam at his mouth a little bit. He was rocking the paradoxical breathing. The brother was in distress, crying, and it just, yeah, that's what I saw. And from there, I don't know if Earl had heard this noise or the family member calling out. He came back like he did that night most of the time, and Dr. Husel gave another verbal order for more medication.
Do you recall the medication and the amount that he gave a verbal order for?
The second time,
Yes.
it was 10 milligrams of Dilaudid and 10 milligrams of Versed. Once again, I didn't pull those medications. Earl came back with a lot of medications. He had those medications, but he also had Ativan as well. I don't know where that came in. I don't know. He must have talked with the doctor. While this was happening, and I can't remember if it was right before dose number 2 or right after dose number 2, I can't say, but I called the pharmacy. Called and spoke to pharmacist Talon Schroyer, and I told Talon Schroyer, we are doing a palliative extubation on a patient that has a really big opioid tolerance. He said, wait. He pulled up the MAR on his end. I pulled it up on my end. We could see every medication that was out of the Pyxis. And I said, this is what we're doing. This is what we're giving. But I also have this Ativan, an additional Versed, that I don't think I need because the doctor said give him what he needs, but not too much. So I was calling to say, hey, this is what we're doing. These are the meds that I'm giving. But then also, I was also calling him to say, hey, I also don't want to be responsible for these other medications that the patient doesn't need, and the physician said he didn't need them. I don't want to be, they were handed to me. I don't want these I don't want to be responsible for these. What do I do about that? And like I said, I couldn't remember if that was before or after dose number 2, but I ended up giving the 10 milligrams of Dilaudid and 10 milligrams of Versed. I later then returned the medications that we didn't use.
That would have been the Ativan?
And I think there might have been even Versed there as well, but I know that there was, at least Ativan was returned. There was a weird discrepancy in the Pyxis where it appeared like we gave him more Versed than what I actually administered. So the total dose that the patient received was 1,000 micrograms of fentanyl, 10 milligrams of Versed, 10 milligrams of Dilaudid, and 10 milligrams of Versed, all in the, in that time that I detailed. And then we returned whatever medications were left over because we didn't want to give him too much.
So when you return, does that sometimes show up on the Pyxis log as wasted?
I think so. I say return. It very well could have been a waste. I know that I went with the nurse who pulled them because that was who the fingerprint was on who got them out, and we did something to take account that they're not being given to the patient and being disposed of properly. Either returned or wasted, I don't remember. I just say return because that's what I think.
All right. Let's talk about the call to pharmacy.
Yeah.
You recall on your first palliative extubation calling Greg White.
I did.
You recall seeing Greg White on the floor thereafter.
Yes.
You recall him at least going to the room with Dr. Husel.
I just remember him being on the floor.
Okay. You're not aware whether or not he actually had a conversation with Dr.
No, I
Husel.
wasn't. If he did, I wasn't a part of it.
You did not testify about calling pharmacy on the second palliative extubation.
Correct.
Now, this third extubation, you did call pharmacy because of this Ativan, that Earl Huron, is that who we're talking about?
Well, it wasn't just because of the Ativan, but that was a part of it, yes.
All right, and talking to Talon.
I did.
And so this would have been the first time you have talked to Talon about these drugs, these doses, and what the particular procedure is being used for?
Yeah, to my knowledge, I had never spoken with Talon in regards to a palliative extubation before. I had talked to him numerous times because he was a night shift pharmacist, but in the context of withdrawing on a patient, that was the first time I called Talon, and I told him that we were doing it for a palliative extubation.
All right. Was there another reason calling Talon besides the waste? Or the extra drugs, I'm sorry, besides the extra drug?
Yeah, just like, I think I was just kind of like, hey, we're giving these medications because this guy's a chronic opioid user. To me, it's just, that's a lot of medications to be out of the Pyxis at once. So I wanted him to know this is what they're being used for, this is why they're being used. It's a guy who has a very big tolerance to medications because he was admitted, and it turns out that there was something with his drug use. And then I also didn't want to be responsible for medications that were just freely floating around the unit. So it was kind of twofold.
Was it a common practice in the ICU at night to have one nurse pull medication and then hand it off to another nurse to administer that medication?
I wouldn't say that it was common, but I can't say that it's uncommon. You know, like in a code situation, nurses would hand medications across the patient as you're doing CPR and say, that's epi, push it. You know, there are nurses who would grab bags out of the Pyxis for you. If you're in a room, you're like, hey, override this or not override, I'm sorry. That's not the word I wanted to use. Grab this medication for me, please, just because I'm in the room and you're at the Pyxis. So maybe that's not the best practice per se, but that occurred on the unit.
Okay. And going back to whether this is an emergent situation or not in your mind, is this palliative extubation of James Timmons an emergent situation requiring, like, you described a code with the epi thing, right? That's
Yeah.
an emergency, that someone's flatlined, right?
That would be what the code is, yes.
Is, in your mind, James Timmons the same type of emergency?
In my mind, I do. I do believe that to be an emergency. I see rapid clinical decline. I see a night full of swinging blood pressures, vasopressor use. The family is distraught, and now he's asking for more medications. Like, to me, that is, I would say that's an emergency for me.
Yeah, well, I'm talking about initially, because didn't Earl pull the 1,000 and the 10 initially too?
Well, I don't know why he pulled those. I mean, I know he did pull them, but I wasn't a part. I can say that if Earl didn't do it, I probably would have overrode those medications too. But I don't know if Earl thought it was an emergency or not. I have no idea what he was thinking.
Did you ask Earl to pull those medications though for you?
I don't know. I don't believe so. I'm not sure.
Was Earl part of the care of James Timmons that night?
He wasn't assigned to him, but Earl was very helpful in his care because he had experience as a nurse and was my neighbor. He was taking care of patients next to Mr. Timmons. So it was very common in practice for nurses, even if you weren't assigned to care for that patient, you would go in and help because they're people that need help.
Sure. Well, since this has been brought up as an issue, a possible issue, were you stealing those drugs?
No.
Were you aware of anyone stealing those drugs?
No.
These practices that you describe, I'm sorry, I've been told to be quieter. So, these practices that you've described, and Judge, I look this way just to project that way. If I can just kind of do it this way.
That's fine, just.
Okay. These practices that you've described of one nurse grabbing them, giving them to you to administer, to your knowledge, did that involve anybody stealing drugs? To your knowledge?
No. Everything that was ordered, I received in their entirety, and I drew them up and pushed them.
Okay.
Nothing was unaccounted for. If the order was 1,000 of fentanyl, there was 1,000 of fentanyl there.
All right. And if the records reflect that you gave Mr. Timmons 1,000 of fentanyl, that's actually what occurred?
Yeah, I gave it to him.
All right.
Intravenously.
And then you also gave him at 3 o'clock the midazolam too, the 10 milligrams of midazolam?
I did.
All right. So how soon after giving those drugs did Lynn come out and say he's still in pain, or whatever he's saying to you, he needs more pain medication? How soon after that initial dose do you recall giving him that second dose?
Roughly approximately 5 minutes, 5 to 7 minutes maybe.
Your knowledge in 2018, how quickly does fentanyl and midazolam work in a person's body?
I think you need a little bit more sustained.
Were you aware of how quickly midazolam and fentanyl worked in a person's body in 2018?
Specifically, no.
Okay. So you hear Dr. Husel give another verbal order at 3:05. Does that sound right? You said about approximately 5 minutes later?
Yeah, roughly.
Hydromorphine, that's also Dilaudid. That's just the name brand.
That is correct.
10 milligrams of that,
Yes,
and that was IV push.
it was.
And then another 10 milligrams of midazolam,
Correct.
and that was also IV push.
Yes.
And that was pulled by Earl because it was kind of urgent at that point.
I think it was Earl or Emma, yeah. I think Earl, I'm comfortable saying Earl.
All right. And did you prepare those doses, or did Earl prepare those doses, or did Emma prepare those doses?
I don't know about the second one.
All right.
I'm the one who gave it.
And you have a memory of giving those doses IVB push at 3:05, approximately?
Approximately, I do. I was the one who administered them.
What happened next?
The patient's family member thanked us for more meds, and we went back to our standard outside the room. You know, I kind of monitored the situation for a second. I suctioned his mouth because there was the stuff hanging out of it. He looked, the paradoxical breathing was maybe a little bit better, but I left the room. You know, to me, it's more about the family being in the room. You know, I want to stop being like, oh, let me do this assessment, let me do this. Like, the vasopressors are off. Like, those are out of your system and very quickly. Like, he needs to be here, and I need to step back here a little bit. It's less about me and more about his last moments being with his family member.
Okay. Prior to his extubation, do you recall whether or not you charted any active pain in Mr. Timmons?
I let Emma do most of that charting, so if it was, it would likely be under Emma, aside from the dose that I gave palliatively when I recorded a pain score.
Okay. Is there anything I could show you regarding whether or not pain scores were charted during this time?
Yes, please.
Okay. Showing you from Mr. Timmons' medical records the direct charting flow sheet. I was just going to show him this. May I approach the witness, Your Honor?
You may.
Thank you. Does that help refresh your recollection as to whether any pain chart, in the pain chart, if any pain scores were recorded?
Yes, it helps refresh.
What were the pain scores that were charted during your care of Mr. Timmons?
Emma, and which I guess means me, charted zeros.
Okay. And why is Emma charting that as your preceptor? Are you instructing her, or is she doing this on her own?
I'm letting her do her own assessments. Ultimately that's her charting, but I'm making sure more so that she doesn't record something off the wall like a -2. Like, she had her own process of how she comes to that number. As long as she has a why as to how she got to that number, I'm okay with that. I'm signing off to make sure that she's keeping the integrity of the process, more so than, I'm not telling her, that's a 0 because of this. Like, the way that I would educate is I would allow her to come to her own conclusions, and as long as she had a rationale as to why that is her conclusion, I'm okay with that.
Do you recall that being an issue? Do you recall seeing Mr. Timmons in any pain, grimacing, the things you've described, which would indicate pain for somebody on a ventilator, that would indicate Emma's not correct there in the 0 pain score?
I do believe he's on a fentanyl drip at the time. So what I can say to that is maybe he didn't need a PRN breakthrough while on our shift, but he was already requiring something to control pain. So I don't know if that answers your question.
Well, the question is did you observe Mr. Timmons to be in any active pain while you were taking care of him?
I'm not sure I can recall that.
Did you ask for clarification from Dr. Husel in front of Emma when these doses were ordered initially?
Yeah, both times.
And what was the purpose of asking for clarification from Dr. Husel? This is now the 3rd time, and the same doses approximately as the previous 2.
Yeah, sorry. 2 reasons. The first is less important, but it's a reason, is Emma needs to know that she can approach doctors. She needs to see that it's very scary sometimes for people to talk to a doctor and say, hey, what do you mean by this? Especially being new. Fortunately, he was approachable, so I wanted her, she was going to be working, I want her to see that 1, it's an expectation that you clarify. 2, it's okay to question doctors even when it's scary. 3, the doctor that you're going to be working with is approachable and respectful when you come with questions. And then 4, I'm still seeking that same clarification. At the end of the day, I'm still responsible for that patient. So it's kind of fourfold. It's an education thing for Emma, but it's also like, hey, this is still Mr. Timmons here. This isn't, as much as Emma's education is important, Mr. Timmons is the priority here. So I need to make sure that we're on the same wavelength as to why we're administering these dosages.
Okay. So that was October of 2018, October 24th, so it's the end of that month, getting to the end of that month. In December of 2018, so about 5 weeks later, give or take, do you recall being summoned to HR?
Yes.
Why were you summoned and what happened then?
So I'm not sure I ever actually worked a shift after that. I think I went on like a vacation or something, and I was placed on administrative leave. I was summoned to HR for what they told me was a fact-finding endeavor. That was their words. They asked me questions about ICU practice, about overriding medications, and they asked me about, that's really what I remember.
Okay. Were you thereafter taken to another room and asked to speak to the police?
No, so I actually was summoned to a meeting from HR. I think I met with Katie Barga. I think that was her name. she kind of vaguely alluded to what ended up, what we all know now, but it was very like, oh, this is just us, finding some facts, nothing's gonna happen, stuff like that. Then, give or take sometime later, I was called and said, hey, come to Mount, because I'm still on administrative leave, so that's my job. They say, come to Mount Carmel West. It's not the hospital, but there's an attached building, which is like where the big wigs sort of have their offices. Come there, we're gonna do a little bit more questioning. I went there, so it's the second time I went back, and I was told then, spur of the moment, that I'm going to meet with Columbus homicide detectives.
Did you thereafter meet with them
Oh yeah, I did.
and made a statement?
Oh yeah.
Okay. And what's the next thing that happened regarding, you were on leave from what date, do you recall?
I don't recall. I know that what ended up happening with me.
Okay, I'll permit the answer for now. Go
Just
ahead.
at Mount Carmel is all I'm talking about.
What happened next?
And I'm talking about when were you placed on administrative leave, if you recall, from Mount Carmel? So this was before you met with the police, you're already on leave?
I think. It's vague to me because I ended up leaving Mount Carmel. I resigned on January, I believe, 19th or mid-January, I resigned from that position.
In 2019?
2019, yes.
While you were on leave?
While I was on leave.
Okay, very good.
They had,
Okay,
I'm sorry, yes, I'm done, yeah.
we do by question and answer.
Yes, sir, I'm sorry.
Just a few more questions about James Timmons.
Okay.
You had mentioned that he had been on a drip. You had knowledge that he had been on a drip of fentanyl that evening or previous.
Yes,
Do you recall the amount of drip he was receiving per hour?
I do not.
Is there anything I could show you which would refresh your recollection as to the amount of drip he was receiving?
Yes.
It's right there. It's the 25 micrograms.
Okay, thank you.
Does that refresh your recollection as to his previous drip?
Yes,
What was he receiving?
175 micrograms per hour.
Do you know what that white foam in his mouth you described after you gave him the 1,000 microgram push was from?
No, I have no idea. I know it's secretions. I don't know why it's caused.
Had you seen that before in any other patients?
Not like that. That was significant. Like it was, almost looked like an Alka-Seltzer tablet was in his mouth.
Had you ever treated anybody that was actively overdosing on fentanyl?
Objection, Judge.
Well, I'll permit it.
No.
Thank you. No further questions.
Ross?
What? Oh, I'm sorry. Just, yeah, I gave you one
That's all right,
last
we
week.
got it. Go ahead.
Thank you, nothing further.
Cross?
Please report. Good morning, ladies and gentlemen. Good morning. Good morning, sir.
Good morning.
I want to start from the beginning of your direct. You were asked if most of what you learned, your first, I guess, most of what you learned was from Dr. Husel. Do you recall that?
I recall them questioning me that.
Okay. But you, in fact, had learned quite a bit from your preceptors, right?
Yes, I learned from other nurses, respiratory therapists, and I did my own independent. I said I bought books. I was reading at home. So he taught me a lot, but it was not, I learned from everybody.
In fact, you learned from your preceptors and other more experienced nurses that 1,000 micrograms of fentanyl was an appropriate dose during a palliative withdrawal. Isn't that correct?
I was told that it's patient specific and that would not be, so like that is very well possible.
Okay. Do you recall in another proceeding giving a deposition in this case?
Yes.
Okay. And do you recall that date was February 26th of 2020?
Yes.
Do you recall when discussing Mr. Millett that you testified under oath that it was an appropriate dose?
Yes.
And then later on you were asked, you said you were trained that it was an appropriate order. Who trained you that this was an appropriate order? And then you answered, my preceptors. I mean, just the way that a nurse learns. Aside from that, you know, you gather, maybe in school, you learn primarily how to function in your role. It's almost like a residency.
Yes, that,
Okay, you answered the question.
yeah.
Okay. So you would agree that your experience, on-the-job experience, is quite a teacher.
I would say that is probably the best teacher.
Okay, so if you had certain experiences, you would utilize that in perhaps your next patient that you run into a similar situation, right?
Yeah, I try to store those experiences that leave a lasting impact, and I tap into those for my future treatment. It helps shape my practice.
Okay. Now, I want to talk a little bit about Mr. Millett. Are you familiar, you testified under direct examination about acidosis. Do you recall that testimony?
Yes.
And you utilized it as a gauge as one of the factors as to why you took into consideration
Reasons correct.
Okay, and are you familiar with the pH range that's compatible with life?
Yeah, and I'm familiar, I would have been familiar with that in my practice, back then as well.
Okay, and you know that it ranges, what's the normal range?
So the normal range, textbook range, is 7.35 to 7.45. For simplicity, most people just say 7.4. That is the scale.
I'll
Yeah.
get into it a little bit more.
Okay.
And I want to show you a document in reference to the scale and see if it looks familiar to you.
Okay.
Coach?
You may. Did you show the other side?
Yes, I did. Does that fairly and accurately describe what you understood at the time that you were working on with these patients, what the pH scale was?
Yes.
Okay. May I publish, Your Honor?
Any objection?
Object, Your Honor, as to its relevancy with this witness.
This is
He's
brought
not an
up.
expert. This is something he didn't prepare. This is nothing he has experience with. He's not here to testify regarding any of that.
Counsel brought out during direct examination his consideration of the pH levels. And this witness is familiar with the pH scale, and this is what he utilized to analyze whether
No,
this
that
was
isn't
an
what he
appropriate
said. He
dose.
didn't utilize that document. That was the first time he saw it.
But he utilized the scale. This is all this is the scale. It's not some document.
Sustained.
Sir, on the pH scale, you said that 7.4 is right where you want to keep your patient, correct?
Yes.
And you're familiar that Danny Millett was at 6.96, correct?
I am familiar with that value.
Okay. And 6.96, or actually, at what point on that scale is it not compatible with life?
For me, in my practice, it begins to tread on fatal at or below 7.2. So if I see anything less than 7, that is significant. That is, we need to either change something or everybody needs to get on board with what the goals of care are. That's not compatible with life. Under 7 is, you won't live.
And could you explain to the ladies and gentlemen of the jury what pKa levels are and how that relates to, based on your training and experience, the pKa levels and how that relates to the administration of fentanyl?
Objection, Your Honor.
Sustained.
All right, let me ask you this. Are the pKa levels something you would have considered when making the determination whether a dose is appropriate?
Objection, Your Honor.
Sustained.
When you questioned, or when you clarified, I should say, the order with Dr. Husel, and he gave his explanations, was the pKa level something you considered?
Objection, Your Honor.
I'll permit that one.
At the time it was mentioned, I did not understand what it meant per se, but it was definitely something that was mentioned.
Okay. Now, you mentioned that Mr. Millett was a pretty sick man.
Yes.
And at the time of his palliative extubation, he was actively dying?
I believe so.
Okay. And when someone is actively dying on full life support, is that an emergent situation?
Actively dying, yes.
Okay. So, when did the family approach you in reference to doing the palliative withdrawal?
What I can say is they were updated with the status, but for Mr. Millett and all of these patients, the decision to switch code status to DNRCC was the family-driven initiative. It was not, every time we would conclude with, we will do whatever it is you want us to do. We will keep going, but if you don't, just let us know. We are there for you.
I forgot to mention this. There was a lot of testimony in your direct about your inexperience and your training. this palliative withdrawal actually occurred a year after you had started, correct?
Roughly, yes.
And this is a year of working in the ICU, correct?
Yes.
A year of working with preceptors or other experienced nurses?
Yes.
And this is having to see several other, or I should say many other, palliative withdrawals, correct?
I've seen other palliative withdrawals, yes.
Prior to ever having to do or be in charge of Danny Millett's palliative withdrawal?
Yes.
Okay. So you weren't exactly a rookie, so to speak?
I don't know what the value is to where you become a veteran, but I had seen some before. This was not my first palliative withdrawal.
Okay. Now, you mentioned that Dr. Husel would sometimes pull you aside and train you as well as other nurses?
Not just nurses, techs, even people that are just like stocking rooms that want to go to school, respiratory therapists, everybody who worked on that unit, he was an open resource for.
And this is a teaching hospital, is it not?
Yes.
So it's not unusual to teach other healthcare professionals while on the job, correct?
I agree.
And in your experience, Dr. Husel was always approachable?
Oh, 100%. I mean, he was... I have been at many different hospitals previous to that and since that, and there has not been another physician that I have encountered that didn't make himself available as he did, didn't freely educate as he did. Sometimes it's like pulling teeth to get them to give you something. And I've seen him go what I believe is above the duties that some of the physicians I've worked with usually do.
Now, you have, as your experience grew in Mount Carmel, you then became part of what is called a code team, did you not?
Yes, I was part of the Code Blue team.
Tell the ladies and gentlemen of the jury what that is exactly.
So since ICU nurses are required to have, or at least at Mount Carmel, they were required to have advanced training in life support measures and saving people in emergencies. I had that, and I have that. 2 nurses from the ICU would be placed on what's called a Code Blue team, as well as the attending physician in the ICU, which some nights would be Dr. Husel. So what that means is anywhere, any place in the hospital, if there was a code where a patient died, those 2 people, the 2 nurses and the doctor, would be responsible for going to that location and trying to bring them back.
And is this something that an ICU doctor has to do?
I don't know. I know that,
Okay, you answered the
yes,
question?
I don't know.
But you say that Dr. Husel, I guess, during work would go above and beyond.
Yes.
Okay. And as a member of the code team, did you have the opportunity to do codes with Dr. Husel?
I've done a lot, yes.
How much is a lot? Give us a little more context. More than 50, less than 50?
More than 50, I think a good number is 70, 75.
So about 75 times you witnessed Dr. Husel saving lives.
Well, it's on the code team, yes, but there's more than just that. You know, I can recall a moment where there was something paged overhead. It was a level 1 trauma. So
at this point, I'm going to object as to relevancy.
Sustained. It's time for lunch anyway. Ladies and gentlemen, if we start back up at 1:15, will that give you guys enough time for lunch? Well, which would you prefer? Not that it's your decision, but it's mine, but 1:15, this door safe? Okay. Remember the admonition, we'll get started accordingly.
All right.
Have a great lunch, guys. Sir, you may be excused until we come back at 1:15. Remember my prior ammunition. Mr. Byers, you're on the floor. Anything for the record?
Nothing from the defense.
Mr. Zion?
No, Your Honor, thank you.
Both of you two have taken shots at me about what I told you the other day. Okay? Really? You're gonna act like that with me?
No, I'm not acting.
You made the comment about alluding to him getting too close and directing in there. You made the comment about being directed out. I'd be more than glad to explain to the jury. I don't think you want me to.
No,
Why I did. So, you know, you can take your shots, but let's do it at an appropriate time. You're not bothering me what you're doing right now, and Mr. Zion wasn't bothering me what he was doing. Okay? It's when you got all the way over by the rail and got in there that bugged me.
I did, Judge?
Yes, you did.
I wasn't aware I did that, Judge, and I apologize if I did to both court and counsel.
It wasn't today. This is from the past.
Oh, okay. Yeah.
Okay?
I'm aware.
No one got over there today. Mr. Zion came over because he had to bring the exhibits, but he got out of the way of the jury, which was fine. Okay?
Sure.
Anything else for the court?
No, sir.
Have a great lunch, guys. 1:15.
called it the medical records from count 4, from Joint Exhibit 4.
Joint Exhibit 4,
Identify what it's labeled.
you were previously shown this. Let's see if I can zoom out. Okay, here we go.
It'll do it for you if you just hold it still for a second.
Got it. And do you see at 2015 on the 5th of December, you noted that he was on 100% oxygen. Is that correct?
That's correct.
All right. Now, what's that going to do to a person once they get taken off of 100% oxygen and the room only has 20 when you need 100 to breathe?
Objection.
Sustained.
When you were asked on direct examination about, or you spoke of the oxygen levels, why did you bring that up?
That is a good indicator of how sick and injured a person's lungs are.
Is it an indicator of how long they may breathe after being taken off the ventilator?
Objection, Your Honor.
Sustained.
Based on your training and experience and what you've seen during palliative extubations, is it an indicator of how long a person will be able to breathe for once taken off the ventilator?
Objection, Your Honor. He doesn't have this knowledge.
Sustained.
Now, sir, you mentioned, well, the prosecutor had asked you in reference to the order for the fentanyl. He mentioned to you, do you recall that your testimony that it was a verbal order?
It was a verbal order.
Okay, I'm showing you Joint Exhibit 4, page 168 through 169. Do you see that, sir?
Yes.
And do you see the patient name there? Is Danny Millett?
Yes.
And I'm showing you on the bottom an action time at 21:23 on the 5th. That's at the time of the ordering of these meds, correct?
Yes.
And it's specifically the fentanyl, the 100 microgram, I'm sorry, the 1,000 micrograms?
Yes.
Do you see what it says here?
It says entered and electronically signed by Dr. William Husel.
So does that indicate to you that it was a written order by Dr. Husel?
Yes.
And I guess you also just entered one in verbally, is that correct? You have also entered one in, correct?
Yes.
Is that maybe where the confusion lies?
It could be.
Okay. Now I want to talk to you about when you spoke with Danny Millett's family. You testified under direct examination that, and I wrote this down, discussed all of the things we were going to do. Do you recall saying that under direct examination?
I recall that.
Tell us about all of the things that you discussed.
Yeah. So on top of the prognosis with him that we detailed earlier, we talked about how we're going to turn off the IV pumps, which contain the vasopressors. We talked about how we were going to discontinue the ventilatory tube. We were going to take out the endotracheal tube, put a little bit of nasal cannula on him if he needed it, and we were going to give him pain medication, that would help him be comfortable and pass naturally as a result of his underlying illness.
Did you discuss with the family the potential side effects of the medication?
They were discussed.
Okay. And did you feel that the family, what was it, did you feel that the family was well informed by both you and Dr. Husel?
Yes.
Okay. And that included being well informed of the potential side effects of fentanyl?
I think so, yes.
Now, I'd like to move to Mr. Allen. Oh, before I do,
Okay.
Mr. Millett was on 3 vasopressors, correct?
Yes.
And he was receiving the maximum dose of those vasopressors, correct?
In my best recollection, it was very high, yes.
And despite being on 100% oxygen and 3 vasopressors, he was still actively dying on this life support.
Yes.
You told the jury during direct examination that vasopressors act very quickly. Is that correct?
Yes.
Okay. How quickly, in your training and experience, do you see when you turn off vasopressors that they stop working?
Objection, Your Honor.
I'll permit the question in that format. In your observations
Yeah.
as a nurse, that's what he wants to know.
About 1 minute, 30 seconds to 1 minute.
So in 30 seconds to 1 minute, the jet fuel that's keeping him alive is turned off. Is that correct?
Well, it's turned off and then it begins to lose its effectiveness in about 30 seconds to 1 minute.
Now, let's discuss Mr. Allen.
Okay.
You discussed on direct examination, again, that this was also a very sick man.
Yes.
He had COPD,
Correct.
and that affects the lungs, correct?
Yeah. Yes.
And what does COPD stand for?
Chronic obstructive pulmonary disorder, maybe? I'm basically, it's an issue of the lungs, and it can be secondary to smoking or just the natural aging process as we get older.
Okay, and Mr. Allen was also on vasopressors,
That is correct.
and he also suffered from coronary artery disease.
Yes.
So that's, his lungs are not well, so is his heart. Is that correct?
Yes.
Now, you mentioned that Mr. Allen was I guess in your direct testimony, you mentioned that Mr. Allen was at the ICU and then he would return to the floor. Do you recall that?
Yes.
And then you also testified that while on the floor, they had trouble reaching the doctor. Do you remember that testimony direct?
Yes.
Okay. And that he was paged multiple times?
Yes.
No objections? Okay. I'm showing you Joint Exhibit 8, page, it looks like 846.
I see that.
Okay. Now, you mentioned that Dr. Husel is always available, or very available.
Yes, he would freely walk around the unit and be available to us, the nurses.
And in this note that you testified under direct, you see the nursing note, I have paged Dr. Mangan at least 10 times and he has not called me back. Operator paged him and operator called me back and said Dr. Mangan hung up and hasn't answered.
Yes.
Okay, and then further down on the note, it says, Dr. Mangan called back after several pages, and this nurse reviewed vitals and everything that has went on over the last few hours, notified that son John would like to speak with him. Physician will try and call, but it will be a few hours. Notified of blood pressure now, and the ICU orders need to be discontinued and monitors needed. Do you see that?
I do.
Okay. It was at this point, after not receiving the proper care, that made Mr. Allen return back to the ICU, right?
Yes.
So basically, Mr. Allen had a procedure,
Twice.
Okay, and after the procedure, he was doing okay in the ICU?
He was doing okay enough to be transferred out.
They transferred him out, and his blood pressure dropped,
Yes,
and they couldn't get a hold of the doctor.
that's correct.
And when they did get a hold of the doctor, he gave him some salt water and thought his pharmacology was probably as a result of the surgery.
Yes,
Okay. And then he ultimately ended up having a cardiac arrest in the morning.
yeah, he died.
Oh, I mean in the ICU, yes, in the ICU that morning, correct?
Yes,
And it was later when you came on the night shift and had to take care of him. Is that correct?
yes.
Now, you mentioned that this gentleman was beyond sick and he was coughing up blood. Do you recall that?
And it led to aspiration pneumonia, yes.
Okay. And you also testified that his vent settings required more support.
Yeah, he had what we call an ARDS ventilator setting.
What does that mean to us lay folks?
Acute respiratory distress syndrome. So, and I would have known this at the
Okay,
time.
answer
Yeah.
the question.
Sorry, sir.
Okay.
We've been through this once.
Sure, I was
You were just repeating it. I understand.
going to say I was just transitioning, but
This is attorney humor, ladies and gentlemen of the jury.
having said that, you mentioned, well, Mr. Allen was also on 100% oxygen, correct?
Yes,
And also on vasopressors, correct?
yes.
Now, you were asked about paralytics at this point. Mr. Allen was not on any paralytics, correct?
Nothing that on my, no, he was not on a continuous infusion of paralytic.
In fact, you didn't see anything in the record, or you, during your care, never gave him any paralytics.
To my knowledge, no.
Okay. And you said that when you were approached, that you were sitting at the nurse's station, and the family approached you.
Yes,
And it was, when the family approached you, it was with the intent to withdraw care, is that correct?
yes, that's what I recall.
And it was at that point that that's not something you could do. You needed to call Dr. Husel to hear the family express their wishes, correct?
Yeah, I could not, it's out of my scope of practice to make that change, so I called the physician to the bedside.
And it is at this time that you also discussed the withdrawal of care, including the palliative withdrawal, correct?
Yes,
And you testified on direct that the patient was not stable, correct?
correct.
Okay. And you didn't discuss on direct examination, let's see. And you didn't discuss that conversation with the parent, with the family, excuse me, of Mr. Allen. I'd like to get into that a little bit. Was everything discussed with Mr. Allen's family?
Yes,
And including the potential side effects of the fentanyl?
yeah, yes,
And was it your belief that they had all the information they needed?
yes,
And if Dr. Husel had not given all of the information needed,
Objection, Your Honor.
would you have,
Sustained.
okay? Is it your custom and practice to ensure, whenever you're doing a palliative withdrawal, that the family has all the information they need?
yes,
And did you feel, in Mr. Allen's case, that they had all the information?
I do.
Now, you had noted that, and you're going to have to forgive me, sometimes I can't even read my own notes. It says, withdrawing and grimacing, okay? And do you recognize grimacing and withdrawing as a symptom of pain?
Yes.
Okay. And you, however, it was pointed out that there were no, what was the pain noted for Mr. Allen?
I believe it was noted as a 0.
Okay. And is that because things move quickly in the ICU?
Yes.
And you sometimes
Okay,
make
hold
errors.
on, I'm lost here. You gave it a 0 because things move quickly in the ICU. Is that how I understood your testimony?
Oh, no, I gave it a 0 because at the time of that particular assessment, I did not appreciate the presence of pain.
Okay.
Let me clarify. I think I asked it poorly, Judge. So if things are happening quickly in the ICU, do you always have time to chart right then and there?
I do not.
And is it fair to say that while you may try your best, sometimes the records don't give the full picture of what's going on?
Yes.
And in this situation, do you think that's the case with Mr. Allen?
I do.
All right, now I'd like to move to Mr. Timmons. Now, Mr. Timmons, as we've already covered, was an overdose patient.
He was a patient who presented secondary to an overdose, yes.
And he, of course, had heart issues.
Yes.
And rather than go over all of his medical issues, fair to say he was extremely sick.
Yes.
And when you arrived, you said that you saw the crash cart outside of his room.
That's correct.
And before you can get a complete update as to what was going on in his condition, his blood pressure started dropping into the 60s.
That's correct.
Now, it's at that time that in an emergency situation, you summoned Dr. Husel.
I told somebody to get him, yes.
Okay. Well, you summoned him. You got
Yeah,
somebody to get him.
yeah.
Okay, so he comes running in, right?
Yes.
And when he gets there, Mr. Timmons is actively dying, correct?
Yes.
And he doesn't order 1,000 mics of fentanyl and say, all right, let's just end this right now, right?
No, that didn't happen.
In fact, tell the ladies and gentlemen of the jury, well, you kind of went into some of it during your direct, and I don't want to have to repeat all of that, but there were multiple life-saving measures employed at this time, right?
Yes.
In fact, one could classify it as numerous.
I would agree to that.
Would you agree that Dr. Husel, in his interventions here, did everything he possibly could to save Mr. Timmons' life at this point?
Yes.
Okay, sustained. Ladies and gentlemen, disregard the last answer and question.
Okay. He ordered sodium bicarbonate, correct?
Yes.
To correct the acidosis.
Yes.
He ordered glucose, correct?
Yes.
He ordered calcium to increase his blood pressure.
And to stabilize the cardiac membrane, yes.
He then ordered epinephrine, which is a vasopressor, correct?
Yes.
To increase his blood pressure.
And help the heart pump, yes.
He ordered hydrocortisone to increase the blood pressure, basically to help the vasopressors perform better.
Yes.
He ordered vancomycin.
Vancomycin.
Yes. A second antibiotic to help fight infections.
Yes.
Meropenem, a third antibiotic to address the infection.
Meropenem, yes.
Yes. Then he ordered norepinephrine
Yeah, that's another name for levofed, yes.
Okay, and that's also to keep the heart beating and increase his blood pressure.
Yes.
He then ordered insulin.
Yes.
He then ordered another dose of calcium. Another sodium bicarbonate.
Correct.
And then 1 hour before withdrawing care, he then maxed out the vasopressors.
That's correct.
Have you ever been in a situation where a patient was dying like that, actively dying at such a high rate of speed where you had to institute so many life-saving measures prior to Mr. Timmons?
Yes.
Okay. And would you say this was right up there with that?
What do you mean by that? Right up there.
Sustained.
I'll withdraw the question. Now, you testified that the brother, Mr. Timmons' brother, was it Lynn?
Yes.
Okay. Lynn had approached you and told you, it looks like we're going to be able to get through the night, correct?
That's what he said.
And what exactly did you say in response to that?
I said, I don't even think about it that way. I can't say that. I'm trying to get through the next 30 minutes to 1 hour.
Did you at that time instruct him not to leave the hospital?
Yes.
Did he leave?
Yes.
And then how long before you felt you had to call him back?
Shortly after the second time that the patient kind of had a similar presentation to the beginning.
And after going up on the vasopressors, and when he came back, did you give him an update as to what was going on?
Yes.
And as the nurse addressing a patient, who has more contact with the patient? Is it the nurse or the doctor?
I mean, I deal with the patient more than the doctor.
And who has more contact with the patient's
Well,
family?
hold on. Your question was with the family? He said the patient.
I'm asking both.
Okay, well, that isn't the way it come across to me, so let's rephrase it.
Sure. Let me rephrase it. Who has more contact with the patient? The nurse or the doctor?
Nurses.
Who has more contact with the patient's family? The nurse or the doctor?
Nurses.
Okay. And when he came back, when Lynn came back, you gave him all of the information that I guess you updated him with the care?
Yes.
And what did he say to you in response after giving him an update?
It is then that he made the decision that he wanted to withdraw care. He said that his brother wouldn't want to live this way, to take all the SHIT away, and that's whenever I went and got Dr. Husel.
Okay. And it's at this time that Dr. Husel came and you guys discussed the palliative withdrawal?
With the patient, yes. Or with the patient's family, I'm sorry, yes.
Brother, right?
Yes.
And did you have a thorough discussion with the brother?
I believe so, yes.
Was he advised of the potential side effects of fentanyl?
Not specifically fentanyl, just he was advised of the side effects of the pain medication we were going to give.
Okay. And that would include respiratory depression, potential respiratory depression?
Yes.
Okay. So we're clear on we've been hearing a lot of terminology being thrown about as it relates to respiratory. Tell the ladies and gentlemen of the jury what respiratory distress means.
Yeah. To me, respiratory distress would mean that the patient is actively fighting to breathe, fighting to move air in and out of their lungs. It's something that you see. It's something that you can visually see where they're sort of sometimes tripoded over, huffing and puffing, kind of the muscles in their neck and the muscles in their sides are kind of working hard. It's an exhausting process it could be an exhausting process for the patient to remain in respiratory distress.
Now, tell the ladies and gentlemen of the jury what respiratory depression means.
Yeah, respiratory depression would be a reduction in the frequency in which you breathe.
And this is based upon your experiences and your dealings.
Yes.
I'll preface it, Judge, that way. So based on your experience as a ICU nurse, sometimes the opioids are given to address the respiratory distress.
Yes.
Okay. And that is accomplished by respiratory depression sometimes, correct?
Yes.
Okay. And then there's respiratory arrest. Tell us what that means.
In my experience, that is the complete the complete inability to breathe. You can't move air in, which leads to a heart attack, and you die.
Okay. So those are all three different things, correct?
To me, yes.
Okay. Now, you stated that after extubating Mr. Timmons, that at some point the brother, Lynn, came running. Is that correct?
Yes.
And what exactly did he say?
He's in pain. He's in pain. Somebody come. He's in pain.
Now, I wrote down that you said, help, help, somebody do something. Did he say that?
He said, help. He's in pain. He's in pain. Somebody do something.
And you testified that he was gray and blue?
I guess I'll just say discolored, just because that's subjective.
Okay. And are you familiar with the phrase bad death?
Yes.
And is that what you believe you were seeing with Mr. Timmons?
Sustained. Ladies and gentlemen, disregard the question and the answer.
What is a bad death, sir?
Sustained.
Based on your training and experience.
Sustained. This is our discussion the other day.
Okay, I'll move on. Now, after this is when Dr. Husel ordered more pain meds, correct?
After the brother came out of the room.
And
Yes.
this was to address the symptoms that Mr. Timmons was experiencing at that point in time, correct?
The second dose, yes.
Okay. And that is when you needed the assistance from other nurses?
There were other nurses helping, but I was using their assistance far before that.
Okay. And after getting all of this medication from the Pyxis machine, you felt it was prudent to, at this point, call the pharmacy to let them know what was going on, correct?
I called the pharmacist, yes.
And you testified in direct that you spoke with Talon Schroyer,
Yes,
and you're familiar with Talon Schroyer's voice?
yes.
Okay. And you testified in direct that he brought up Mr. Timmons' chart at the time and saw the meds that he was being given?
We were simultaneously looking at the MAR.
And it is at this time that you told Mr. Talon Schroyer the fact that Mr. Timmons had a history with a drug history, correct?
I said he had a drug tolerance.
And speaking of tolerance, you're aware that Mr. Timmons was given 14,000 micrograms just a few hours earlier for that surgery, correct? Or a day before?
I'm aware that he received 14,000 micrograms of fentanyl.
And that's not including the 25 microgram drip that you mentioned during direct examination?
That is my understanding,
And
yes.
that's also not including the 175 microgram drip that you discussed in direct examination, correct?
Yeah, yes.
But while pointing out those two, do you recall testifying at all on direct examination about the 14,000?
I'm not sure I was asked that.
Okay. You don't recall that though, right?
You've asked it twice now.
Again, what you were seeing by Mr. Timmons appeared to you, based on your training and experience, to be painful, correct?
Yes.
And Miss Emma Young had marked it at 0, correct? The pain score?
I testified to that, yeah.
And again, this is another example of, would you agree that this is another example of the records not telling the true and accurate picture, correct?
Wait a minute. Let's go sidebar. I haven't done it all day, guys. I'm trying to be better. We can go with it another day. We can get there. Okay. I heard that. Hi, guys. We gotta let the court reporter get caught up to us. She has to get caught up to us. You guys can't hear me? Whoa. Damn. Can you hear me now? Okay. We have to wait for the court reporter to catch up to us. Okay, you ready there, Madam Court Reporter?
Yes, sir.
Mr. Baez.
Mr. Diemer, I think my last question to you was, and this is another example where the records don't always tell the complete and total picture, right?
Yes.
And in fact, are you familiar with the expression, there's nothing like being at bedside?
Yes.
Do you agree with that statement?
100%.
In fact, nowhere in the records does it say that that Mr. Timmons was foaming, correct?
That's correct.
And nowhere in the records does it say that he was having these agonal breathing, correct?
I don't believe so, no.
And nowhere in the records does it say that he was turning gray or blue?
No, it doesn't.
And just so I'm clear, whenever you are doing a palliative withdrawal, some of the things that you look for or you're concerned about based on your training experiences, one is pain, right?
Yes.
The other one is suffering, correct?
Yes.
And that could be the patient suffering or the family suffering as they're witnessing their loved one die.
Yes.
And then the other one is, of course, respiratory distress.
Yes.
Now, that's not an all-inclusive list, right?
It's not.
Okay. Now, I'd like to show you the medication order set that's been shown in this case a couple of times, and that's Defendant's Exhibit MCD 16. Do you see that?
I see this.
Okay. And it's specifically for palliative withdrawals?
Yes.
Okay. And then this one is the one that was the policy, the effective
Counselor,
date.
where are we going with this? He's not an ER doctor, he was a nurse.
I'm aware of that, Judge, but he is
So
familiar.
why are you showing this to him?
I have a couple of questions about it. He's familiar with these. I'm aware of him being familiar with these.
So? Help me understand.
Sure.
Ask your questions, make your record,
Okay.
and we'll see where it goes.
All right, I'm going to start with 15. This is an order set that was effective between 2010 and 2016. Do you see that?
Yes.
Okay. And under medications,
Okay. Sustained. He wasn't even there during that period of time.
all right, I'll try and see if I can discuss it another way, Judge.
I believe that was his
Oh, okay,
testimony.
you're right, there's another one, sorry. Okay, from 16 to 19, you were currently working there, correct?
I was employed there, yes.
Okay. And under medications of this order set, the very first thing that's written here as a guide for withdrawing terminal patients.
I would object, that's a foundation at this point. It doesn't-
Yeah, a little bit more foundation, I agree. Okay, we're both talking, my fault. He objected. Speak up. Go ahead and get your objection on the record.
Foundation.
Okay, I'll sustain. Let's lay some foundation with
Sure.
it.
Mr. Diemer, you're aware of this order set policy, correct? Or guide, I should say.
I'm aware that doctors can use an order set for this, for pulling the tubes.
And in fact, you brought this to the attention of the prosecution, did you not?
Objection, Your Honor.
What's relevant?
My
Sustained.
last question would be relevant, Judge.
Okay,
We'll
well,
tie it
it's
together.
sustained now. Tie it up then, real
Okay,
quick.
sure. Do you see where it says, after withdrawing of terminal patients from ventilator support, principle of double effect, as a note?
Okay, that doesn't tie it up.
Sir, are you aware of any guides or policies that address the issue of the principle of double effect?
Objection.
Sustained.
Here we go sidebar.
Yeah, absolutely.
Sorry.
Hi, guys. David? They Okay, you ready there? You ready, Sam? Okay, ladies and gentlemen, the objection was sustained or disregard the last question.
May I have just a moment, Judge? I want to.
You may. For some reason, that clock now has a glare on it. I can't see it as well as I did before.
Okay, do you have that? Sometimes the boss instructs me what to ask. So. Let me ask you this, Mr. Diemer. Do doctors wear the same color scrubs as nurses at Mount Carmel while you were working there?
No.
Okay. What color do nurses wear?
We wear blue.
Okay. And what color do doctors wear?
Sometimes they wear street clothes. Most of the time they wear a white coat.
Okay. Are there scrubs dark blue?
I'm not sure.
But the uniforms or scrubs that are worn are clearly distinguishable between a nurse and a doctor, correct?
Yes.
Okay. And you're currently working as a nurse where?
Objection, Your Honor. Hey, Husel.
Oh, okay.
Strike the last question then?
Yes, let me ask you this. Ask this way. I apologize. What position do you hold currently?
I am a certified registered nurse anesthetist.
Okay. And what does that entail exactly?
It entails earning my master's degree and studying anesthesia, which I did. And now I am still a nurse, but I am now licensed to administer anesthesia. And what that entails, my job duties are to assess a patient, formulate a plan for the patient's surgery, corroborate with the attending physician, the anesthesiologist, my plan and his plan, provide the anesthesia, pain medicine, all of the things necessary for them to have a safe surgery, successfully put a breathing tube in most of the time, and then most importantly, wake them up.
And this is something you've been studying for quite some time, including while you were at Mount Carmel, correct?
Yes.
I have no further questions.
Redirect?
Good afternoon, Mr. Diemer. Let's go back to where Mr. Bias started with the question about where you learned 1,000 micrograms of fentanyl was an appropriate dose. Do you recall that question?
Yes.
Okay. And he referred you to a prior sworn statement at a previous hearing?
Yes.
Okay. And do you recall the scope of where you said you learned that in that previous hearing? The scope of where this was an established practice?
I'm not sure I understand. I'm sorry.
He's asking you, when you answered that question earlier in the deposition,
Yes.
what experiences was that based upon?
Oh,
As your nurse or as your new title?
No, I wasn't
No?
asking that, no.
Okay, I'm sorry.
Yeah, this is all about back in 2017 when this is
Okay,
going on.
go ahead and then ask the question again.
All right. Was this a hospital-wide thing, or was this the unit, meaning the Mount Carmel ICU at nighttime you were referring to, where this was an established practice?
it was, I only know the ICU, so I was speaking to the ICU.
Okay. So this was the established practice of the ICU at night, because that's the only thing you ever worked, right?
Yeah, yes.
Okay. And that's where you learned 1,000 mics was okay.
Yes.
And this would have been in 2016, 2017 when you started.
Yes.
And you know when Dr. Husel started.
Do I know when he started?
Right.
I think the previous year, 2015.
Okay. We heard testimony 2013. Does that sound right based on your prior relationship?
Sustain, it's outside the scope.
Okay. But who's teaching the nurses that work the nighttime ICU?
Objection. Cause for speculation.
Okay. Rephrase the question.
Who is teaching the nurses based on your observations? Who's the teaching person there?
Objection.
Finish the question.
Who's the teaching person there in the nighttime ICU during your tenure there?
Okay.
Objection.
I'll permit the overruled. You can answer.
It's many people.
Who's the main one?
I can't answer that.
Objection, Judge.
Well, if you can't answer it, I think that's the answer. Did you see Dr. Husel readily teaching everybody? Was that your testimony?
Yes.
Nurses,
Yes.
the people that stock the shelves,
Techs, yes.
techs, right?
Yes.
And were there any other doctors on shift with him at that when he worked?
Yes.
I mean, in the ICU.
Oh, no.
All right. actively dying equals an emergency. Do you remember that line of questioning?
I do.
And who trained you in that?
I'm not sure I've ever been trained. I don't think anybody ever has specifically said if somebody's actively dying, that's an emergency. I think that is my recognition of those 3 emergencies was my independent assessment of the situation.
You talked about your interaction with the Allen family, or Mr. Allen's family.
I did.
Do you recall the family approaching you and asking you, can we wait 20 minutes until midnight because that's his birthday that night?
Not that I remember.
Based on your review of the medical records, would there have been an issue of waiting 20 minutes so he could have turned 81?
Objection, Judge.
Can you answer it?
Can you just, can you tell me again? I forget what you asked.
Based on your review and understanding of the medical records in 2018,
Yeah.
you've gone through them extensively, you've testified about a lot of details on them.
Yes.
Would there have been an issue of waiting 20 minutes to do the palliative extubation and the administration of those medications?
I'm not sure. Things change in the ICU.
Can you describe the person, looking back in your mind, who you say approached you about the withdrawal of life-sustaining care?
I don't remember.
You don't remember anything, gender, age, looks,
No.
in any way?
I only remember that interaction based off of my charting, and that is when a family,
That's not mine. Go ahead, I'm sorry. You don't remember?
No, I don't remember if it was a man or a woman.
All right. Regarding Mr. Millett, remember the questions on cross about the toe being amputated and his bypass surgery, the vascular bypass surgery done on his leg?
Yes.
That was not during this hospitalization, was it?
That was correct. That's correct.
That was from a previous hospitalization back in November, which is not too distant in the past, but a week or two before.
That's correct.
Right. And it was a question to you about the 5 cardiac arrests, and then it was changed to 4 cardiac arrests. Do you know actually how many times he coded in the ER?
Numerous.
Okay. You don't know if it was 3, 4, 5?
I can't, the records are blurring together a little bit at this point.
Okay. And at the point that you're seeing Mr. Millett that night, would you have scoured those records to see those things and to take that into account in the dosing of Dr. Husel?
How many times he coded? I would have, that would have been something I had in the back of my mind. Typically for me, in my practice, 1 code is enough with the right with the person doing CPR to break ribs. So anything after 1 kind of blurs together for me.
And let's be fair, your practice is the doctor gives you a prescription and you fill that prescription, right?
Objection.
I'll permit it. It's transitional.
He gives an order and I satisfy that order if appropriate.
Okay. So you are not the prescribing authority,
I have no prescriptive authority.
and you still don't have prescriptive authority.
I do now in my current role.
Okay, I meant throughout your course I meant when you're seeing Mr. Millett or Mr. Allen, et cetera.
Correct. I would need an order.
So are you the one making these decisions about the dose, the type, and the timing, the way this medicine is going to be delivered, et cetera, during this?
I'm not the person who signs off, but it is a care team directed decision.
And as you stated, as a nurse, as part of that care team, you have the ability to, in your words, clarify with the prescribing doctor.
And pharmacists and other nurses should you need to.
And in these cases, you clarified each time these orders with Dr. Husel.
All 3 times.
And in 2 of those times, you clarified these orders with pharmacy, or at least you recall seeing pharmacy the first time, Greg White,
Yeah. Yes.
and you do recall a conversation with Taylor Schroyer.
Yes.
All right. Did you testify at a previous hearing that in fact it was your understanding Greg White had authorized prior to administration of those medications on Mr. Millett?
I'm not sure.
You don't recall testifying to that?
I recall having depositions, but I don't recall that specific statement.
Do you recall testifying then that you later found out that that was not accurate, that Dr. Greg White had not authorized?
Objection.
Do you remember having that during the testimony?
Are you talking about learning after that he found, or learning after the fact that he didn't verify that, or was that what you're asking me?
Yes.
I said that somewhere, yeah.
You talk about how quickly vasopressors act and how quickly, within 30 seconds to 1 minute, they stop acting, right?
Well, they begin to decline in their action.
Is it your testimony, did you mean to say on cross-examination that it was the care of Dr. Magin that caused Mr. Allen to go back into the ICU? Is that what you believe the medical records show, or the lack of care of Dr. Magin?
I can't specifically say it's Dr. Mangin's fault, but I came from an environment where if I needed a doctor, he was readily available. So was Dr. Hagras. So when I hear about a patient who's rapidly declining and there's orders or there's progress notes that say they can't get a hold of them, I think a delay in care could have led to some harm there.
That would be speculation on your part regarding the care Dr. Magin gave him?
Sure, or didn't give him, yeah, sure.
You were not present for any of that?
I was not there, no.
Okay. However, it did reference the family and how involved they were and how insistent they were about the care Mr. Allen was receiving.
In terms of the son wanting to speak, or that family member wanting to speak with him, yeah, that's correct, that was written.
And is it your memory that the entire Allen family and everyone that was there was that persistent about the care Mr. Allen received?
Objection. Leading.
I'll permit it.
I wasn't in the room for that. I don't know.
You don't recall the Allen family being there? As is evident by the note regarding Dr. Magin.
Well, and they were in the room, obviously, and had to be updated, which led to them coming out and finding me, voicing their desire to withdraw care.
All right. And that's your memory of how it happened, but you can't tell this jury about anything about that person looking back in your mind's eye.
No, I just can recall being approached by a family member.
All right, let's talk about the family member on Mr. Timmons.
Yes.
You know his name, you remember him, Lynn, right?
Yes.
All right. Do you recall calling Lynn multiple times during the night after he had gone home and asking him to change his brother's status to DNRCC?
I recall calling him, but I never would have said, hey, you need to come in here and change this code status. That would not be something I said.
Do you remember calling him multiple times?
I remember calling him, yes.
And once again, multiple times. Like you remember calling him, was it once, twice, 3?
Oh, I'm not sure the number.
Do you recall that Mr. Timmons had a son that was driving up from North Carolina?
No.
Objection, Judge. It's not Mr. Timmons. Mr. Hayes.
It's not? Oh, sorry. Oh, well, there you go. Sorry. Please, if I could, I will withdraw that question.
Withdraw the question, ask
My
a new
mistake.
one.
I
Okay.
apologize. You were asked questions about respiratory depression. You recall that?
Yes.
And you recall testifying on cross-examination regarding your knowledge of respiratory depression at the time of these palliative withdrawals?
Yeah, I answered that.
Okay. So you're aware of the phenomenon, correct?
What phenomenon?
Respiratory depression.
Yes,
You understand what it is medically.
I believe so.
That was your testimony. But you were not aware of the package inserts on midazolam and/or fentanyl regarding the known effects of respiratory depression.
Objection, leading.
Okay, he's asked, I'll permit the question, but I haven't heard it all, so finish up your question and I'll rule.
All right. Were you aware of, but you were unaware, or were you aware of the known respiratory depression effects of midazolam and fentanyl individually?
Okay, sustained.
Were you aware of respiratory depression being a side effect of fentanyl at the time?
Yes,
Were you aware of respiratory depression being a side effect of midazolam at the time?
yes,
Were you aware of the synergistic effect of those two drugs when given at the same time?
Objection.
It's as to his awareness, I'll permit it.
At
Fear.
that time?
At that time.
Yeah, that's what he said.
it was just that, it was a theoretical concept that was briefly covered in training.
Okay. And what training are you talking about? Was this training that you received during school or training you received from Dr. Husel?
My answer there was referring to my clinical, so that would have been my education, my school.
So did Dr. Husel ever talk to you about the synergistic effects of fentanyl and midazolam being used together causing respiratory depression?
I don't think so.
Regarding the death of Mr. Timmons, the two doses, the 1,000 micrograms and the, how much midazolam did he get?
The first time 10,
Okay. Those are given at what time did the MAR indicate?
I wouldn't be comfortable saying. I could see it, and that would help me.
Was it 3 p.m.? Does that help? 3 a.m., excuse me? And then I can get them out again. Do you recall that being,
Roughly, approximately,
all right?
it was after midnight.
And then, do you recall testifying about the 5 minutes?
Yes.
Later? The time frame we're talking about was within 5 minutes. You say he came running out and told you he's still in pain?
Yes, I remember that.
All right. Do you recall Mr. Baez asking you about the amount of fentanyl he had received during surgery and during his hospital stay previous to the palliative extubation?
Yes.
Had you added that up yet in your mind
Have I?
at the time of the palliative extubation?
I did not sit there and add it, but there was a running total on the bottom that allowed you to see just what he got in the drips. But that was not something, I didn't include other breakthrough medications, OR dosing, things like that. I knew, though, that bag of fentanyl had been refilled multiple times, which left sort of a running total at the bottom.
All right. But once again, these are not your decisions regarding the amount and type of drugs. These are Dr. Husel's decisions, correct?
He's the prescriptive power.
And you said one of the things that was in your mind was that because of what you knew that he was had been at least reported in the medical records, an opioid user on the street, that he had an opioid tolerance, right?
An opioid tolerance.
So 1,000 mics, 10 milligrams. What about Mr. Millett, this 74-year-old guy that came in? Was he a known opioid user out on the street?
To my knowledge, no.
And what did he get?
1,000 and I think that was 4.
And Mr. Allen, the 81-year-old man, was he a known opioid user out there on the street?
He wasn't using street drugs, no.
All right. And what did he get?
1,000 and I think that was 6. And then there was 2 of hydromorphone.
Okay. And in fact, Mr. Millett, when he came in, What medication had he received prior at all during his hospital stay there?
I think you said Tylenol.
Well, is that what's in the medical records? You've had a chance to review them?
Yeah, I had a chance to review them for Mr. Millett. I'm just thinking, I'm sorry. Yes, that's what I remember.
So you would agree, or would you agree, that the guy with the known drug tolerance from the street who had surgery and everything else got, at least initially, the same as Mr. Millett and Mr. Allen, as far as fentanyl goes?
Objection.
It's patient specific.
So these 3 patient-specific doses for the fentanyl were 1,000 micrograms?
That's what we settled on.
The medical records don't always tell the whole picture. Remember that line of questioning with with defense counsel?
Yes.
All right. You do have time to sit down after the fact and chart these things out, right?
After the morgue care and taking the patients to the morgue and things, yes.
Okay. So you would have had time, had you seen the pain and things that you've testified to that aren't charted, you would have had time to go back and put those things in the medical records at some point after the fact.
There was time to do that, but I didn't.
So we have Dr. Husel at bedside, we have you at bedside, we also have the family members at bedside, right?
I agree.
You had to go back and review this, Danny Millett, James Allen, and Mr. Timmons, right?
I reviewed them.
Because these were one of thousands of patients that you cared for during your time at Mount Carmel, right?
That's correct. I cared for a lot of patients.
So those families that were there,
Objection.
I haven't heard the question yet, but go ahead and give me the question.
the families that were there at bedside for their loved ones, right? Based on your training and experience, is what they observed in your mind valid?
Objection. Calls for speculation.
We got a hand up. You need a break? Okay, we'll get you here in about 2 seconds here.
This is my last one.
That's your last question?
For this witness, yeah.
Okay.
I was saying, I don't know, let me go through stuff. Yeah, that's it.
Rephrase the question because technically he's correct.
Okay. You saw family members for Timmons at bedside.
Yes.
You saw family members for Allen at bedside.
Yes.
And you saw family members for Millett at bedside.
Yes.
And they could see and observe, based on what you saw, everything that was going on too, correct?
Yes.
Thank you, I have nothing further.
Okay, you can step down. We'll take our break a little early, but I'll give it to you. Looks like you could use it. David, call him up.
All rise.
Remember the admonition, 15 minutes, guys. We'll get started back 10 till. I think from looking at that clock, I like it now as a reflection. Have a great break, guys. Okay, David, bring them.
Okay, all rise.
Take a deep breath. Just relax.
Thank you. Please be seated.
Okay, ma'am, I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God? Okay, go ahead and seat. Make yourself comfortable there. You've got an aerial mic in front of you.
Okay.
I need you to state your name and then spell it for my court reporter so she can get used to your diction.
Okay. My name is Jamie Burke. It's Jamie. Last name is Bourke.
I know you got more than that. Can you give me a little bit more volume? Can you guys hear okay?
No?
Say it.
Okay. All right.
Knock them down.
My name is Jamie Burke. Jamie Bourke.
Miss Mick,
All right, thank you.
call your witness, even though she's already there.
Yes, the state calls Jamie Burke.
Okay? Go ahead.
Miss Burke, where did you grow
Oh,
up?
one thing. We're gonna go for this till 3:30, at which point in time we have another one on the video, and then we'll break her testimony and then hopefully finish her up by the end of the day. Maybe not, she may have to come back. She's got outfit issues she wants to talk about, but other than that, I'm just funning with her, okay? Ladies and gentlemen, so we're gonna go with this till 3:30, then we're gonna go live on the screen, okay?
Thank you. Miss Burke, where did you grow up?
Here in Columbus, Ohio.
And where did you attend school after high school?
I went to Columbus State Community College for my associate's degree in nursing, and then later on I finished up my bachelor's at Ohio University online.
Give me a little bit more volume there, okay?
Okay.
Okay. What year did you receive each of those degrees?
The associate's degree, 2009, end of 2009, and then the bachelor's end of 2016.
And when did you begin working at the Mount Carmel Hospital System?
I worked there since 2004 as a PCA first, and then I became a nurse in 2010, and then I got a job there as a nurse.
When you got a job as a nurse, what unit did you start in?
I started in a medical intermediate care floor. It was called 6 Tower. It was med surge, kind of a catch-all sort of floor. I worked there for 5 years.
Can you give us a brief description of what that job entailed?
So I had 4 to 5 patients each shift. I took care of my patients as far as like med pass assessments, normal nursing stuff. And then I was a charge nurse at some point, which meant that I was more in charge of my own patients and all the other nurses on the floor, all the other techs on the floor. And I was a preceptor also on that floor, which is just helping new nurses. They work with you.
After the 5 years in that unit, where did you transfer to next?
I transferred to it was like a research program. It was called the Procedure team. I did that for 7-8 months before I went to the ICU in 2016.
And what were you researching in that role?
We were doing research on trying to decrease the hospital-associated or hospital-acquired infections.
And did you say you went to the ICU after that?
Yes, correct.
And around when was that?
Around 2016, February-ish of 2016.
Did you have any training or orientation when you joined the ICU?
Yes, so in the very beginning, when you're a nurse, you have like 10-12 weeks of working with another patient or another nurse. When I went to the ICU, you went back through another orientation period, 10-12 weeks of working with another nurse in some classes that you have to take, and some online classes and in-person classes.
Did you have any specific training on palliative extubations?
No, just with another nurse.
And when you started in the ICU, was your work similar to your work in the other units?
No, ICU is completely different. Different type of patients, different type of medications, different assessments. Everything is different when you go to the unit.
What shift did you typically work in the ICU?
I worked the night shift, usually 7 p to 7:30, 8:30, whatever time you got out of there. But when I was in orientation, I did some day shifts, and sometimes I would come in at 1500 and do a 16-hour shift.
And what doctors did you work with?
Their night shift doctors was Dr. Hagris, Dr. Husel, and then we were a trauma center for a while, so we had some trauma residents, surgical residents, and trauma attendings.
Now, when you're starting a shift in the ICU, how do you get up to speed on, well, how do you get your patient, first of all?
We start all in the break room. The charge nurse for that night kind of gives us all of our assignments, lets us know what's going on, gives everybody their, if you're on the code team that night, you get assigned to the code team, or the STEMI alert, those sort of things. You get all of those assignments.
Can you slow down just a
Sorry.
little bit? I didn't understand the last thing you said after code team.
Okay. They assign the code team, they assign for STEMI alerts, which is just a heart attack or a stroke alert.
To interrupt you, could you spell that for the record?
Oh, STEMI is S-T-E-M-I.
Go ahead, you can continue now.
Okay. And then you go and get bedside report with whichever nurse is off-going.
What is that bedside report typically like?
The nurse gives you a overrun of overview of what is going on with your patient, why they're there, all the different medications they're on, anything that happened within that last shift, and anything that you're expecting to happen, anything that didn't get done that day too.
Okay. I want to take you to January 14th, 2018. Were you working that night?
I was.
And what patient were you assigned?
That patient was Miss McDonald in room 7.
Is that Brandy McDonald?
Yes.
Okay. And did you have a meeting with the nurse from the shift before to get you up to speed on Miss McDonald's condition?
Yes.
Had Miss McDonald been your patient prior to that night at any point?
No, although I was aware of her because I worked that night before morning-ish when she came into the unit.
What was your understanding of Miss McDonald's clinical status when you started your shift?
Do you want me to give you an overview of everything, or just when I
Yeah,
started?
just generally what was her. Yeah.
So she was so young. She was 37. She had ovarian cancer that had spread to her lymph nodes and to her liver. From what I understand, she was on the our regular oncology floor. She had been in a clinical trial, which is like an experimental treatment at our Zingmeister Center, which is just Mount Carmel's cancer center. And those medications that she was on, they were worried were hurting her liver, and so they had sent her to the hospital to get treatment for that. That night, 13th going into the 14th, she had become really short of breath, and the doctor had been called to the bedside. She wasn't doing well. She ended up going to a CAT scan and then coming to us. And that's when I knew of her because I was working that night. And I was in room 6. The floor doctor and Dr. Husel were in the nurse's station right in front of me. And the floor doctor was telling Dr. Husel about this patient that wasn't doing well. I think he was upset because her lactic acid was really high and he hadn't been notified of that. And he was telling Dr. Husel about him, and Dr. Husel was like, just bring her now, we'll take care of her. It was like almost shift change. So that's when they did bring her after the CAT scan to room 7. The other nurses took care of her, and there I think that was when she went into respiratory arrest, and Dr. Husel intubated her, got her stabilized. Then, we all went home. So then that night was when I came back in. So 7 o'clock, that's when I had her. She was assigned to me. The off-going nurse had told me that she had continued to get worse during the day. They, family and the daytime physicians had talked, and they decided to change her code status to DNR CCA. She wasn't getting better, she kept getting worse. They tried continual renal replacement therapy, which is like dialysis that we do in the unit continuously, and her blood pressures dropped down into the 60s. She was put on Levophed, which is a pressor that helps increase your blood pressure. She was put on vasopressin, same thing, helps increase your blood pressure. She was on a bicarb drip that was to help for her acidosis. Her pH at the time that when I came on was like either 6.8 or 6.9. That is not good. It is not good at all. Her lactic acid was like 27. So really she was in the part where she was, she was actively dying at that point. I was told that she was maxed out on her pressors, which just means that we can't go any higher on those pressors. And they gave me the last ABGs. They had it on a sticky, a sticky note, and that's why I remember it. And she was getting a bolus to try to help increase her blood pressure, because I think at that point her pressures were in the 70s.
Okay, thank you. I'm going to show you.
Oh, you said ABG?
ABG is an arterial blood gas, kind of gives us.
I just wanted to know what it was. You guys use acronyms all the time.
I'm sorry.
I get confused, so.
I already showed these to defense, and we've agreed just to publish
Okay.
instead of walking back and forth. I'm going to show you States Exhibit 5E. All right. Down here at the bottom, is this one of your nursing notes from that night?
Yes, that's one of my nursing notes.
And could you tell us the significance of what you were charting and why you were charting at that point?
So when you come on, we do assessments. So first thing, I had gotten a report and I went to do my assessment. Her blood pressure was still low even after she had gotten the bolus, and that's last lactic is what was on the ABG, what was her lab results. So I was calling to let him know what her lab results were and what her blood pressure was.
Right. And then turning to the next page of States Exhibit 5E. Is this your next nursing note from that night?
Yes, but we had other things that went on in between there. But yes, that's my next nursing note.
Okay. I guess could you tell me what other things went on in between where we were and entering the DNRCC code change?
So earlier in the day, I think the chaplain's notes and the physician's notes had said that if she continued to deteriorate, that family wanted to withdraw care. So they wanted to do a terminal withdrawal or a palliative withdrawal. So at the point that she wasn't getting any better, and I had let Dr. Husel know, the family was either in the waiting room or he was calling them to come to the bedside to let them know that, she wasn't getting any better and what did they want to do. And this next note is where all the family was there. I believe the chaplain might have been, I don't know.
It's okay, I know it was a long time ago.
Yeah, I was there. Dr. Husel came in to speak with the family to let them know that she wasn't doing any better and to ask what their next steps. Did they want to keep her the DNR CCA and we would continue to do what we're doing, or did they want to go ahead and withdraw care, which is what they had said earlier in the day they wanted to do.
Okay. To the best of your memory, who all was present from her family for this meeting?
She had a lot of family in the room. I know that her mom and her dad and her boyfriend, husband, her long-term boyfriend, was there in the room.
And as a result of this discussion, is that when the code status was changed?
Yes, that was, then I received orders for the palliative withdrawal.
Okay, and can you tell me about those orders?
Sure. So Dr. Husel gave me an order for 1,000 of fentanyl, 1,000 micrograms of fentanyl, 6 milligrams of Versed. I went into room 6 to put those orders in. I put in a palliative withdrawal order set, and I put in the order for 1,000 micrograms of fentanyl. I notated on there that it was for palliative withdrawal, very clear what it was for. I put in the order for Versed. I then went and talked to my charge nurse because I didn't do these very often. I wanted to make sure I was doing it right. I talked with him and asked him if he would go in with me to do the palliative withdrawal.
When you say him, sorry, are you referring to your charge nurse?
My charge nurse. That nurse that day was named Jason Schultze,
Okay.
and I do not know how to spell his last name.
It's SCHULTZE.
Okay.
Continue.
That's to help and not
Yes, to help
interrupt.
Sam, not for you, yes.
And he said that yes, he would go in with me. I just mentioned to him, I was like, hey, he ordered 1,000 mics, and he was like, yeah, he does that. And I was like, okay. I went to the Pyxis to get the medications out. I overrode just like I would have done with any other physician giving me a verbal order with a bedside procedure. Removed the medications. As I was removing the medications, another nurse, Tyler Redmond, had come up to me, saw what I was doing, asked me about what I was doing, told me that I needed a bigger syringe, went to our storeroom and got me a bigger syringe. And so then I took my meds and my syringe. I went to room 6. I didn't have a patient in room 6 at that point. We have all of our supplies in our rooms. So I drew up the medications while I was drawing them up. They're in little vials. Dr. Husel was standing there talking to me, and he was like, oh, you have to, do all those little ones. And I was like, yeah, this is kind of a pain. And he was like, oh, well, in the OR, we have them in 400 microgram vials. So they're, in a bigger vial in the OR. And he said, this is the dose that we give before we do the first incision for open heart surgery. And I thought, well, great. If it's enough to cover the pain for open heart surgery, then obviously it's going to be enough to cover the pain and the distress that this lady is going to have when we remove her from the ventilator and she, in essence, suffocates to death. So I said, great. Finished pulling all of that up, got my charge nurse. We went into the room. I don't remember if all the family stepped out or if only, I feel like there was one other person in there because I remember warning them that there was going to be a noise because there's a gurgling noise when you take out the endotracheal tube. And so we gave the medication, turned off all the medications that were keeping her alive, and withdrew the tube. Then family came in. I believe the chaplain was there at that time also. I left the room. I went to the nurse's station to catch up on all my charting, everything that we had just done.
Okay. To unpack a few things that you just touched on, when you removed the medication from the Pyxis, did you say that was via override?
Yes.
And were you doing that, was this a planned procedure or was this more of an emergent situation?
It's not an emergent situation, but it is urgent. But I didn't override because it was emergent. I overrode because it was a bedside procedure, that the physician is there giving orders, and in that case, we are allowed to.
So Dr. Husel was standing with you?
He was within the nurse's station, within eyesight. I don't believe he was standing right next to me, whereas when I was pulling it up, he was standing right there with me.
And to clarify, did you wait for a pharmacy review before pulling that?
No, they reviewed and approved it later.
All right. Why did you take the vials of medication to the separate room?
Because that's where all of our other syringes were, like the syringe for the Versed for me to be able to pull up all of our flushes were, all of our needles are. So that's where I went to get them all.
Right. And after you said you left the room after you administered the medication, how did you come to learn of Miss McDonald's death?
So we have monitors, like the monitors in the room, you can turn to a certain setting so the family doesn't see or hear all of the beeping, but we can still see it at the nurse's station. So I could watch on the monitor at the nurse's station.
And what would you see on the monitor then?
You could see her respiratory rate, you could see her heart rhythm. She had an arterial line in, so you could see what her blood pressure is continuously. You could see what her saturations were for her oxygen saturations. And did I already say heart rhythm? I think so. Anyways, heart rhythm, that too.
And were you the person that called the time of death?
No, I'm not a doctor. Doctors have to do that.
So would that have been Dr. Husel?
Yes.
Was he with you at the time or when you're watching the monitors, or did you have to notify him after the fact?
I don't remember.
Okay. And I would like to go through some of the medical records with you. I think that you were referencing, well, before we switch off of State's Exhibit E5, were these your final two nursing notes of that night?
Yes, so after someone passes, you have to call all of their consults and let them know.
And is this the 2205, is that the time of death that would have been called?
That is the time of death, yes.
And then just looking at this one, the 2130, is that when the conversation would have taken place?
Around that time, yes.
For the DNRCC?
Yes.
All right, so State's Exhibit 5F. Starting with this respiratory rate, could you describe what that is and what you're charting here?
So the respiratory rate, they have monitors on or leads on that go to the screen that tells you what the respiratory rate is all the time. Respiratory rate is just how fast or slow you're breathing. There in the beginning with the other nurse, she obviously was breathing pretty fast, 39, 38. 2130 is around where I extubated her. So 2151 was minutes after, 2151 is where I extubated her, so, or around there. So her respiratory rate was 19, 2156 was a few minutes after that. It was just another vital sign charting that I did, and then 2205 is when she had passed.
So does the 20 indicate that her respiratory had gone up after extubation initially?
Yes.
And then is the 0 is when it goes down for the time of death?
Yes.
All right. On the second page of State's Exhibit 5F, can you discuss what this pulse oximetry is and why you're documenting that?
So that is another vital sign that is taken continuously. This is how much oxygen basically is in her blood or that she's getting. You want them to be between 90 and 100, which is a normal. So she was still on the ventilator at 2130. You can see her saturations are 95. 2151 is when I had extubated her. You see her sats are now 78. 2156, they're 49. Obviously, they're going down because she is dying.
Going to page 3 of this exhibit. Starting here, the device FiO2 percentage.
So that's how much oxygen she was on with the ventilator. The ventilator has different settings, and you can have it set to where it does the entire respiratory cycle. It breathes for you, so how much oxygen you're giving, how long their inspiration, how long their expiration is, how many times they're breathing a minute, and that's just, they were on 40% of oxygen.
And then turning to the pain scores, looking at these last two, when you documented the 10, was that is after the decision to do the DNRCC, correct?
Correct. That was when I extubated her and gave her the fentanyl.
Were you observing pain at that time, or was this an anticipatory pain score?
This is an anticipatory pain score, what I thought.
Could you elaborate on what that means?
Sure. So when someone's on a ventilator, completely dependent on the ventilator to breathe, and then you remove that, they are no longer going to be able to breathe, or at least breathe well enough to keep themselves alive. And when you remove all the medications keeping them alive, that in essence they suffocate to death. So that was me saying, I think this is going to be incredibly distressful and horrible for my patient, so that's why I'm giving her the fentanyl.
And had you observed her to be in any pain prior to giving her that 10?
My first assessment there is 1944, and I put a pain score of 0. When I looked back, when I looked back, I saw like her heart rate was high when I first came in, her respiratory rate was high, so she most likely was in a little bit of pain, and I was too focused on her blood pressure dropping to realize that.
Turning to the next page of this exhibit, is the pain level acceptable?
I charted at 1944 that it was 0, so yes, that it was acceptable.
The next page of the exhibit, looking at the eye-opening response, Glasgow. Could you tell us what that is?
Sure. So that is a coma score that we do whether or not our patient is having certain responses as far as when we call their name, do they try to open their eyes? Do they look at us? Do they have certain reflexes? It's a neurological assessment. She was, all of her organs were shutting down, so I wouldn't expect a response. So since the beginning, or since that morning, she hadn't been responding. She had been unresponsive to us.
Okay. Turning to the next page of this exhibit, the verbal response, is that on the same Glasgow coma?
Yes.
And when you're scoring her a 3, what does that mean?
So the computer adds it up together, and 3 is just the lowest of that coma score. When someone's a 3, there is a order that you have to call LOOP, which is our organ procurement here in Columbus, Ohio, and you have to notify them that you have a patient that could possibly be an organ donor, is why you have to call them.
Now, looking at the next page of the exhibit, where we see oral secretions, and you put none and see below, could you discuss what that means?
So the oral secretions are just like what secretions she had in her mouth. It would be that next over where it says, is the patient having pain? There was a whole lot of places we had to chart the same things over and over again. So this, if you see where it says T391 and T425, those are just little things that we annotate. Like if you look down, it says patient unable to self-report pain, unable to self-report pain. So that was me charting that.
Turning it to the next page, are these your notes where they had those little T?
Yes, that she was intubated, sedated, that she was over-breathing the vent, and she was guppy breathing. What I mean by guppy breathing is that she was going, and that does happen when someone's pH is so low and when they're actively dying. So, yeah, and that other one is when I withdrew from the ventilator. When you put the pain score in, the program makes you like go through a couple different things, and that's one of those that it makes you do. So that she was unable to self-report pain, that I was giving this medication anticipatory because I was removing her from the ventilator.
And what is the significance of patient over-breathing the vent?
I'm sorry, I didn't hear.
Where it says she's over-breathing the vent, what is the significance of that?
So, one that showed that she was in a little distress or some distress. Like I said, I should I should have noticed that. But so when people are in distress, they're breathing really fast. So the ventilator is set on a certain rate for her to breathe, and she was over breathing that rate.
Then, just looking at this last one, pain relief, when you put C below, what are you documenting there?
So T421, so this is one of our, you see I did it at 2009. This is every 2 hours we have to chart certain safety things, and this is just one of those. Every 2 hours you have to chart, like, what sort of interventions are you putting in place that your patient isn't in pain, or that you're taking care of your patient. And that would be comfortable environment, peaceful environment, positioning, rest. Those are all interventions that we do kind of continuously to help our patient.
And was this and the 0 pain scores before or after the order was given for the fentanyl and the midazolam?
It was before.
Just turning briefly to State's Exhibit 5G, is this the note that you were talking about where you documented?
Yes, so when I put in the order for fentanyl, I specifically put for ventilator withdrawal, so pharmacy would be aware of what I was ordering it for, and I know that I did that because I misspelled withdrawal, so.
And finally, turning to State's Exhibit 5H, is this the medication administration record for Ms. McDonald?
Yes.
And looking at this right here, were you aware of this administration of medication earlier in the night when you started your shift?
I don't remember if I was aware at that point, unless I would have seen it on the MAR.
Did you become aware of it at any point during your shift?
I don't remember.
Okay. The next page of the same exhibit, is this the order for the midazolam and the fentanyl?
Yes, those are the orders I put in, and those are the medications that I gave.
And it looks like, what time was this order put in?
I put them in at they should be 21:31. Yeah, I put the orders in around 21:31 after we had the discussion with the family.
And what time did you administer them?
Around 21:51.
Right. I have no further questions.
We got about 5 minutes before we have to cut. Do you want to do it now, or do you want us to do it all at once?
I don't think I'll be long, but we both know how that goes.
I'm gonna take a chance on you. You're the one who'll get cut off.
It's up to the jury. If they want to take a break now.
We're not taking a break. We're going to go to Dellinger
Oh.
at 3:30.
Oh, in that case, yeah, I will make
Okay.
use of this 5 minutes.
Let's take 5 minutes so we can get the screen set up for the next witness.
He said the other thing.
Oh, you wanna do the questions?
It's all right.
Well, everybody was talking, I was talking to you, so you got everybody's input. You want to do it, do it.
Sure. Good afternoon, Ms. Burke.
Hi.
Just a couple quick questions before we have to break. You mentioned that the pharmacy verified it after the fact, correct?
Correct.
And that was this all occurred, and I'm just showing you I'll just bring up State's Exhibit 5H. The date of all of this occurred on January 14, 2018, correct?
Correct.
And the pharmacist who verified the order was Talon Schroyer, correct?
Correct.
And fair to say that January 14th, 2018 came before October 24th, 2018, correct?
Correct.
I'm ready to take a break now.
No, you're still going,
You
dude.
want me to keep going?
Yeah, I want to see if you can get it done in 5 minutes.
No, I didn't say I was going to get it done.
Ah, you stepped up.
I'll keep going.
Let's get a couple more minutes of it.
Now, having said that, you said you testified under direct examination. I'm showing you Joints Exhibit 5, page 286 to 287. This is the same document you went over with the prosecutor, right?
Correct.
Now, the event was set at 30?
I don't remember.
Okay. Actually, 34. Does that sound correct?
It could be.
If I showed you the order that was entered earlier that day, would that help refresh your recollection?
Yes.
May I approach?
You may, or you can show it to her on the screen. You guys all stipulated the records.
All right. Showing you Joints Exhibit 5, page 172. Do you see right there where the order for the ventilator is set at 34?
Yes.
Okay. So when someone is, as you mentioned, breathing over the vent, that would show, it would have to show over the number 34, correct?
Correct.
Now, here, earlier in the day at 6 p.m., 1838, which would be 6 p.m., she's breathing at 39 breaths per minute, correct?
Correct.
Now, the normal rate, respiratory rate, would be between 12 and 18,
Correct.
correct? So she's breathing pretty fast.
Yes.
Breathing even faster than the ventilator is breathing for her,
Yes.
okay? And she's doing that throughout the day for hours.
Correct.
And right around here is where she gets the palliative withdrawal, correct?
Correct.
Now, can you tell the ladies and gentlemen of the jury about when a patient tires out on their respiratory rate?
You mean as far as within the palliative withdrawal or just
In general, with their reserves.
So at first you would see usually someone breathing fast. They're going to be breathing fast, kind of huffing and puffing. Usually they look like they're in some distress. Sometimes they're like wheezing, that sort of thing. And then as it wears on, then the respiratory rate decreases. As they're tiring out from breathing too fast.
So a person can eventually stop breathing because they've been breathing so fast for so long.
Correct.
Now, when Ms. McDonald had the withdrawal, her breathing was at 19, freshly off the vent, correct?
Correct.
And then it actually went higher, correct?
Correct.
And that was approximately 5 minutes later?
Correct.
And you would have given the fentanyl before extubating her, correct?
Correct.
So this tells you that the fentanyl did not affect her breathing, correct?
Sustained. Good time for a break. Because it's getting close to our time. Ladies and gentlemen, we need a couple minutes to set up. I'm going to send you out of the room. Stretch your legs for a second, and we'll get started in a couple minutes.
All rise.
Do we have Paul? Okay. Just relax. We'll take care of you, don't worry.
Everything, man, just turn around and blame me. God, it's that time.
Okay.
Stuff. That's when we can't get stipulated, so.
Okay. Can you hear me, doctor?
Yeah, I got you.
Okay, well, hold on, we have to get everybody in here. I don't know where they went.
We're all here, Judge.
We're all here? Okay.
Yeah. Before we bring them in, Doctor, I'm Dave Zion. Can you see me?
We're dealing with,
Yeah, I see you.
whoever talks
I
draws
saw
the
you from an
mic.
overhead.
Okay. Did you got the medical records for Sandra Castle, correct?
Yeah, yes.
And did we send you the death certificate as well as part of that review?
Yes, I have that as well.
All right. So I will refer to that as 18L. I don't think we can share the screen using what we have set up.
Okay, you
We all
can.
agree that this is...
You can.
I
Well,
have it on my monitor.
you're looking on your monitor for when you got electronically, correct?
That's right.
Okay. Does that work for everybody?
Yeah, Mr. Lapidus will be doing the cross-examination, but Ms. Menashe says that should work.
Where is he?
Grant the rest of the judge.
We're going to send you all to the doctor this weekend.
We'll start in just a minute here, Doctor. Thank you. It's Mark. Dellinger. D as in David, E-L-L-I-N-G-E-R. Thank you. Well, you can use that as well, so it should be the same as everything. I think we're all set here, Judge. We can get the jury back.
Jurors.
Yeah, okay.
All rise. Thank you. Please be seated.
Thank you, Your Honor. The State of Ohio calls Dr. Dellinger to the stand.
Dr. Dellinger, raise your right hand. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Okay? I need you to state your name for the record, and then spell it for my court reporter, please.
My name's Mark Dellinger, M-A-R-K. Dellinger is D-E-L-L-I-N-G-E-R.
Are you guys hearing him okay? Zion.
Sir, what do you do for a living?
I'm an internal medicine physician that focuses on hospital medicine.
All right. How long have you been so employed?
Came out in 2000, so 22 years or so.
What kind of education starting at college did you get to do what you do?
So I have a bachelor's of science in biology. From there, I went to medical school. That's 4 years. Then there's 3 years of residency, and then I started practicing.
And when did you go to medical school?
I think it was 1993 through 97, I believe.
And where did you go to medical school?
I went to what was called Medical College of Ohio. It's now part of Toledo University.
You said Toledo University?
Right.
Okay. All right. And then what was your residency in, please?
Internal medicine.
Okay. And was this a subspecialty that caring with people in hospital or just internal medicine in general?
It's internal medicine in general was the residency program.
All right. And are you licensed to practice medicine in the state of Ohio?
Yes.
And are you board certified in internal medicine?
Yes.
All right.
It's internal medicine with the focus in hospital medicine.
All right. And you started that, you said, in 2000?
That's right.
And where did you first work back in 2000?
I'm sorry, did you say where?
Yeah. Where was your first job out of residency?
Well, I started a practice doing hospital medicine, and I was at Mount Carmel West, and I was also seeing patients at St. Anne's Hospital in Westerville.
All right. So were you actually employed by the hospital, or did you have a separate medical group that was contracted with by the hospital?
No, I was not contracted with the hospital or employed by the hospital.
In November of 2018, did you have any involvement with the care of a woman named Sandra Castle?
Yes, I did.
All right. And what was your involvement in general? What was your role in general with her care?
I was listed as her attending. I saw her on one day during her hospital stay.
All right. Had you previously seen her outside of the hospital or at any other time?
No.
All right. How did you become her attending?
I see patients, at that time I had seen patients for primary care physicians, and she was assigned to me through that process.
All right. So what do you recall? You've had a chance to review the medical records from this hospital stay that began on November 10th of 2018?
Yeah, the document was 1,000 pages, so I reviewed my progress note and I perused some of the other notes.
All right. So tell the ladies and gentlemen of the jury, please, what was your involvement? You said you saw her one time. What did you do during that one time you saw her?
That's right. So when I saw her, I came into the room and I spoke with her son, who informed me that they wanted to withdraw care on her. Prior to that, I'm sure I had reviewed her records and prepared my note. And then I spoke with the son and had finished my note at that point.
And do you recall what date that would have been?
I'd have to refer to the chart.
Could you refer to the chart to refresh your memory?
11/13/2018.
All right. Do you recall what time that was?
According to the chart, it was at 2:28 p.m. Now that's when, I don't know based on this documentation whether that was when I started my note or when I signed the note. I don't know how that document displays that. It just says 2:28 p.m.
All right. So was this your first and only contact with Ms. Castle and her son during her hospital course between November 10th and November 13th?
Between those dates, yes.
All right. And your note indicates that this was sometime in the afternoon of November 13th?
I may have seen her in the morning and may not have finished the note until 2:28. That's possible. I don't know what time of day it was.
All right, but sometime during the daytime of November 13th, is that fair?
Yes, yes.
All right. Thereafter, are you noted as doing any documentation in the medical records of Sandra Castle for her hospital stay between November 10th and November 13th of 2018?
I did not catch one of the words in there, did I?
Thereafter,
I didn't catch the verb.
Did you do any more documentation, or did you do any more documentation in those medical records?
Not according to what I reviewed.
All right. Did you do a discharge
I
summary?
may have done the discharge summary. Yeah, the discharge summary, yes.
Okay. Tell the ladies and gentlemen of the jury your understanding of the discharge summary in general, and then explain to them what you reviewed to write that document.
The discharge summary is basically a statement regarding the patient's hospital course, and then I would have referred to my note to create that, as well as if I needed to, and I don't know if I did on this chart or not, but if I needed to, I would have reviewed other notes, but I would have reviewed the other notes before I formed my first chart. So it's basically, I would have done some review of the medical records.
All right. In general, was it your practice to review the medication administration record in preparing a discharge summary?
No, not for a patient that was palliative extubation.
All right. And do you have any memory of reviewing the medication administration record of Ms. Castle when you prepared your discharge summary?
No.
All right. So were you, in any other way, were you otherwise aware of the amount of opioid pain medication and or benzodiazepines Ms. Castle was administered during the palliative extubation that occurred that evening?
No.
All right. What cause of death in your discharge summary did you list?
Anoxic brain injury.
All right.
I don't think in that document it was listed as her cause of death, but in the death certificate that was the case.
All right. What was her final active diagnosis in your discharge summary?
I had mentioned anoxic brain injury as well as some concerns for seizures, and I also noted cardiopulmonary arrest.
All right. And were those things that you found in reviewing your note and the summaries that were listed in those records?
Yes.
All right. Thereafter, was it your duty or part of your care for Ms. Castle to sign her death certificate?
Yes, the death certificate would come to me.
All right. And by stipulation, we have sent you that death certificate for the record labeled 18L. Do you have a copy of that death certificate?
Yeah, I'm looking at it right now.
And is that your signature on that death certificate?
Yes, it is.
And what do you put has a cause of death on that death certificate?
Anoxic brain injury.
All right. And when you signed the death certificate, had you at that point reviewed the amount of opioid pain medication and benzodiazepines Ms. Castle had been given in the ICU at nighttime during her palliative extubation?
No.
All right. Thank you, doctor. I have no further questions. There will be another attorney up here in a minute to ask you some more questions.
Thank you.
Just a brief moment to set up, Your Honor.
They're gonna hook up a computer, give us a second.
Good afternoon, Dr. Dellinger. How are you?
Good. Thank you. Good afternoon.
So, one moment. Just at the outset, Doctor, I wanted to clear something up. You indicated on direct examination that you saw Ms. Castle once, and that was it. Is that accurate?
During that hospitalization, that's correct.
Okay, that's what I wanted to clarify, because isn't it true that you actually had seen her several times in the weeks preceding that hospital visit?
I remember on the records that I reviewed, there was documentation that I had seen her during a prior hospitalization.
Okay. Well, let's start. Do you recognize the document in front of you as a medical record for Ms. Castle?
Yeah, thank you. I see her name, yes.
Okay, and do you see, and for the record, I'm referring to Defense Exhibit SC2, or excuse me, SC3, sorry. Do you see your name under discharge summary there, doctor?
I see, yes.
Okay. And this would indicate that you did the discharge summary when she came to the hospital on an admission date of October 27, 2018? It's the course of her care, Your Honor. This is her attending physician for 3 hospital visits prior to the one that ultimately she passed away on. And he took care of this patient.
I'll give you some leeway, but let's tie in.
Go to the next page, please. This is the next page of that document. This is still the same discharge summary you authored yourself, right, doctor?
It appears so, yes.
Okay, and this indicates that on October 30th, when she was discharged, you actually indicate that she had also been in the hospital for a form of internal bleeding a month prior to this as well, correct?
The first sentence states that, yes.
And that she had came back on this date of October 27th with involuntary tremors, correct?
Yes.
Okay. Now, let's go to SC4. Doctor, do you recognize this document as being a medical record for Ms. Castle as well?
I've not seen this, but it appears to be emergency record from November 8th. Maybe I might have reviewed this. I'd have to see what else it says. But.
And again, you're listed as the, sorry, can you go back up?
He's right there.
No, can you go up? You're listed there as the attending physician, correct?
Yes.
And this is for the admission date of November 8th to November 9th, correct?
Yes.
And this is the visit immediately preceding the next visit in which she will ultimately pass away, correct?
I imagine so.
Okay.
Yes. I mean, there's not much time between the two, so I believe so, yes.
Can you go to the next page, please? And you see where it says history of present illness, doctor?
Yes.
Would you agree this is an accurate assessment of her current medical issues that she was experiencing on November 18th or November 8th to the 9th of 2018?
I would have to say that it would be accurate. I have not read this, but
Let's go to the next page.
I believe it would be accurate.
Do you see there where this emergency doctor is or rather the nurse in this note is indicating that she spoke to you when Miss Castle arrived to the emergency department?
I see emergency urgent care, medical decision making. I don't know who wrote this. I see the last sentence, the second last sentence says, discuss care with Dr. Dellinger after workup was completed, and a decision was made that the patient need to be placed in the hospital overnight for cardiac workup of the chest pain.
Do you see there at the beginning where it
I think it would be.
Doctor, do you see at the beginning there where it indicates labs, EKG, chest x-ray, extensive chart review, neurology consultation, pulmonology consultation, cardiology consultation, and the discharge summary were reviewed with you?
I don't know that that means it was reviewed with me. I think that means that they reviewed it themselves.
Why do you think this emergency room nurse decided to talk to you about Miss Castle when she came back for the third time in a few weeks?
Objection, Your Honor.
Sustained.
Is it fair to say that she wouldn't have spoken to you if you didn't have any knowledge regarding Miss Castle's medical problems?
Objection, Your Honor.
Sustained.
Let's go to page 49, please. And you did in fact treat her when she came on the 8th to the 9th that time, correct?
If you would show me a note of mine, I could verify that. But
Let's go to the bottom of this. Would it refresh your recollection to see the note that you made on November 9th, 2018 at 12:15?
yeah, if you show it to me, I could get some idea whether I saw them or not. Looks like this is a note from me on the 9th. Okay.
Does that refresh your recollection as to you having treated her personally on that day?
I don't remember any particulars, but it looks like I saw the patient on the 9th. And yeah, I would say yes, I saw her.
And you made it a point to start that summary with an indication that she in fact is returning back to the hospital with chest pains and tremors?
I note that she returned back to the hospital with chest pains and recurrent tremors. That's correct.
As well as headaches and lightheadedness?
Frontal headaches as well as some lightheadedness, right?
And in fact, she had so much stuff going on, she indicated to you that and asked you whether she was going crazy?
Yes, she asked me if she was going crazy. That's correct.
Okay, let's go to page 7, please. You also did the discharge summary for when she came on the 9th, correct? Or from the 8th to the 9th?
That looks like a discharge summary with my name on it, yes.
Okay, and you see
Well, is that the fourth?
You see the admission date of November 8th and discharge date of November 9th?
Okay, yes.
So this would indicate you did the discharge summary for her the day prior to her coming back to the emergency room on November 10th?
It looks like it was completed on the 14th, according to that document.
Well, we're going to get into that. But is it not accurate that you did the discharge summary for the visit where she came on November 8th and left on November 9th prior to returning in an emergency on the 10th?
I did the discharge summary, yes.
And in fact, you did this discharge summary for this visit the day after she had passed away, did you not?
Yes.
Can you scroll down? And you indicated that she had been observed for transient chest pain and recurring tremors, correct?
Yes.
And she was discharged to go home, was she not?
Yes.
let's go to, for the record, I'm now going to refer to Joint Exhibit 11, page 20. Or, excuse me, Joint Exhibit 12. Thank you. And to your knowledge that Ms. Castle then returned on November 10th as an emergency, correct? Scroll to the bottom, please.
Yes.
And in fact, she had been with her spouse, and he noticed that she was unresponsive and gurgling at home and rushed her to the hospital, correct?
I don't know the details of who she was with.
Okay. And to clarify, you indicated that prior to speaking to her family members, you reviewed the notes of other physicians, correct?
I would have, yes.
And that would include the physicians such as Dr. Mahoney, correct?
It's possible.
Go to the next page. Go to the part right above where it's at. Does it refresh your recollection that you would have reviewed Dr. Mahoney's note prior to speaking to Ms. Castle's family, where Dr. Mahoney indicated that Ms. Castle was critically ill?
Remember, I'm going to object to
Sustained.
testimony of Dr. Mahoney through Mr. Lapidus.
Let's do it right. Let's ask him if that refreshes his memory.
Doctor, in reviewing this note by Dr. Mahoney, does this refresh your recollection as to what you reviewed prior to speaking to Ms. Castle's family?
No, I can't say that I reviewed that record first. I don't know when I generated my note or saw the patient relative to when he entered his note.
Okay. Do you see there, well, can you go back to the previous page, please? Again, we're now on Joint Exhibit 12, page 20. To the bottom where it says consultation. You see there that Dr. Mahoney's note
Once again, Your
is...
Honor, I'm going to object. He says he does not remember Dr. Mahoney's review in that particular.
He didn't actually say that. He said in regards to timing. I'm now establishing the timing of this note in relation to when he spoke to Ms. Castle's family.
Okay, well, you can go there, but the way you're going about it, just let's be a little bit more direct instead of a long trip.
Understood. Doctor, do you see that Dr. Mahoney wrote that note on November 10th of 2018 at 2:21 in the afternoon?
I see the timing on there, but as I mentioned earlier, I don't know if that's when, according to the computer, when that note was started or when it was finally signed off upon. So I don't, that's all I can tell you about that.
Can you go to page 11, please? Okay, just to orient ourselves, Doctor, this is also a note for Ms. Castle for the visit of November 10, 2018, correct?
Yes, this is a note from the 10th, right?
And you are the attending physician, correct?
When she came in, I don't think I was the attending at that point. According to, when this document was generated, it probably drew me in, but at that point, I don't think I was the attending. I think the patient was transferred to my service later.
And that would be when she was transferred to the ICU, correct?
I don't know when it was exactly.
Okay. Do you recall speaking with Dr. Mulkenor? I'm sorry if I butchered that pronunciation. Do you recall speaking with this doctor?
No.
Okay. Would it refresh your recollection to see Dr. Mulkenor's notes regarding the conversation he had with Ms. Castle's attending?
If he listed that he spoke with me, that may help, but I really don't think that we spoke.
Do you see the line at the very end of that paragraph where it indicates that he discussed the case with the ICU attending? And it states that she does have reflexes and was withdrawing for painful stimuli? That would be you, correct, that he spoke to?
No, that's incorrect. I would not be the ICU attending.
Okay. But this is one of those notes that you may or may not remember having reviewed prior to speaking to Ms. Castle's family?
This is the initial, what they call the history and physical that was initially generated when she first came in. I would have referred back to it if I needed to when I saw her. Yeah, I can't say that I did or I didn't.
And you, just to clarify, your company is Columbus Inpatient Care?
No, that's not right.
So you don't have a company named Columbus Inpatient Care?
No, I do not.
Now, you said on direct examination that you saw Ms. Castle once, correct? And that was when you spoke to the family member?
During that hospitalization, the final hospitalization, that's right.
Let's go to page 66. We're still on the same joint exhibit, Sam. We're going to page 66. The bottom, please. Joint exhibit 12. Actually, just go to 67. 67 is fine. Doctor, that indicates you were the author of this note, does it not?
Yes.
And this would indicate that you saw the family at bedside and reviewed the care with them?
She's not, yes.
Okay. And you would agree with me that this is that this is a time in which you saw Ms. Castle and spoke to her family?
On that date, yes.
You would agree with me that there's no references to seizures there?
I don't think, there's, at the bottom of what I'm seeing, I don't know if part of mine's cut off, but it says non-convulsive status epilepticus, which is a seizure.
Okay. Now let's go to page 82. Doctor, do you see here, again, this is a note from Ms. Castle, correct?
Again, Your Honor, I'm objecting to them showing other doctors'
Yes.
notes.
Do you see the word it says?
Hold on. Where are we going with this?
It literally says progress notes, Mark Dellinger. It's his note for when he saw her a second time.
Is that where you're going? Because you showed the notes to somebody else at the top.
Well, it's right there, Your Honor.
You can go on with that note there.
Yes.
The other note doesn't apply to him.
No, I just needed to scroll, Your Honor. You see this second note reflecting a second time you saw Ms. Castle and spoke to her family?
You know what? This is my note. If you could show me the first one, I'm not sure if the first one was mine. When I reviewed the records, I thought I only saw it once. I thought there was a covering doctor. That may have been their note.
Page 66.
I'm trying to look on mine here.
Yeah. We're going to go back to the previous note so we can show you where the timestamp in which you signed that. Okay?
Yeah. So that would have been the 12th.
Doctor, you saw her on November 12th, correct?
When I reviewed the records, I only saw a note from the 13th from me, and I kind of perused the other ones. I really think that somebody was covering for me on the weekend, and then 13th may have been a Monday, and that's when I came on. But I'm happy to look at that 12th note, and I'm trying to find it here. I just don't see it yet.
Doctor, do you have the full medical record in front of you?
I have 1,000 pages, so it's...
I'll make it very simple. Go to page 66, Doctor.
Okay, both of you talking at the same time. Relax. Stop, relax for a second. Let's let him get there. He's dragging you to page 66. Have you found it?
I'm on 66 on my PDF, yes.
You see at the bottom of that page, Doctor, where it says electronically signed, Dellinger, MD, comma, Mark A, November 12, 2018, 1734, Eastern Standard Time?
That is the okay, I see that, yeah.
Now go to the next page, please, Doctor.
Okay.
You see how it says author Mark A. Dellinger, MD on that page?
Yeah. I do.
So do you agree with me that you actually saw her twice during this hospital visit and spoke to her family twice?
Yes.
And you reviewed the course of her hospital care with the family twice, not once?
Right.
Thank you. Now let's go to page 82. Doctor, can you go to page 82 of that medical record, please?
Okay, I'm here.
You see there that is a note from the next day of November 13th, 2018 at 2:28 in the afternoon, authored by yourself?
Yes.
You see there that the son was at the bedside and you discussed her brain injury and her apparent seizure?
Right.
So you would agree with me that when she was at the hospital and through the course of your care and speaking to the family that she actually suffered a seizure at the hospital based off her heart attack and head injury?
Yes, she was having seizures, that's correct.
And it was at that point, based off of her decompensating situation, that you discussed with the family their options, correct?
Yes.
It was at that point that you felt the situation was grave enough to give the family their options regarding withdrawal of care, correct?
I believe that they told me that they wanted to withdraw, and I would have discussed the other options as well.
Would you agree with me that they didn't just volunteer that they wanted to withdraw care, that probably was based off something that you indicated to them, based off your opinion of what her medical status was?
I imagine they would have used my opinion and the opinions of the other doctors to form an opinion.
And again, you reviewed the documents from the other doctors prior to speaking to the family, correct?
I would have reviewed the medical records. Like I said, they may, based on the timing, I don't know whose records I would have reviewed and whose I wouldn't have.
Okay. So to clarify, you didn't just walk in there and talk to her family about her actively dying without having some medical basis for it, correct? Whether it be your notes or your own observations.
Exactly. Yeah, I can't walk in there and not know anything. It just, you have to review things.
Okay. Now let's go to page 6, please. Doctor, could you go to page 6 of the medical record, your discharge summary, please?
Okay.
Doctor, do you see there that this is the discharge summary that you authored after the discharge summary for her prior visit as well?
Yes.
You see there the list of all the different physicians that saw her?
I see a list of physicians, yes. I imagine they saw sometimes in the medical records, you can be consulted, but you never saw them, and sometimes it still shows up, and maybe what your partner saw them. But those are a list of doctors.
Okay, so let's scroll down to active final doses. So I believe you went over some of the active and final dose diagnoses in your direct testimony, but I want to go through the full list of what you decided to put as to her final diagnosis when writing this discharge summary, okay?
Okay.
We have her heart attack, correct?
Yes.
We have respiratory failure. Her lungs stopped working, correct?
That's correct.
She was suffering from COPD, correct?
That's right.
She had chronic heart failure, suggesting she had a history of heart issues, correct?
Yes.
She had hypertension, which is blood pressure problems, correct?
That's correct.
She had hyperlipidemia, which would be cholesterol problems, correct?
That's right.
She, with respect to Ms. Castle, you listed that she was morbidly obese, correct?
Yes.
She had type 1 diabetes, correct?
That's right.
She had unspecified abnormal movements. That would be the seizure she was suffering from, correct?
Yes.
Now, doctor, you'd agree with me that medical records are very important, right?
Yes.
You wouldn't put something there that you weren't confident as to why you were putting that there, correct?
Yes.
You wouldn't guess, would you?
No, I wouldn't.
Now,
No, I wouldn't guess.
and that, doctor, that applies to both the discharge summary as well as a death certificate, correct?
That's correct.
Now, you indicated on direct examination that you didn't review the medical administration record, and you didn't do that because it was a terminal vent withdrawal. Is that accurate?
You're talking about when, after the patient died?
Yes. When you did this discharge summary and the death certificate, you didn't feel the need to review the medical administration record because you stated on direct examination you don't do that for terminal vent withdrawals. Is that accurate?
That's correct.
Now, nothing prevented you from looking at the medical administration record, correct?
Correct.
You had access to it, right?
Yes.
At any point prior to writing the discharge summary or the death certificate, you could have reviewed it had you chosen to, correct?
Yes.
But you felt you didn't need to prior to writing those very important final diagnoses and cause of death on a death certificate, correct?
That's correct.
You were confident in what you put on those important documents because you knew of the care Ms. Castle had received several times, including her last visit, by yourself and other doctors, correct?
Yes.
You were confident that when you put the cause of death was her brain injury on the death certificate, and when you put heart attack on final diagnosis on this document, that that's actually what had caused her death, were you not?
That's true.
And just to end on one last question, doctor, actually two, sorry. You put that her cause of death on the death certificate was natural, correct?
I believe, let me check, double check, but I'm sure I probably did. Yes.
Now, you put that her death was natural, and to circle back as to why you don't review a medical administration record for a patient who's been terminally withdrawn off a ventilator, is it an accurate statement to say that nothing in that medical administration record would have changed your opinion as to what you put on these documents? Because when you do a terminal vent withdrawal, the patient is terminal, correct?
Yes, you're taking them off life support. There's no more support for their life. We expect them to die.
And
Yes.
she was terminal based off everything you put in that active and final diagnosis, correct?
Yes, what's the decision to take her off the life support? I believe that she was terminal at that point, yes.
Nothing further, doctor.
Redirect.
Few notes, doctor. Could you go back to your progress note from November 13th? I think he said it was page 82. November 13th.
82. Let me
Is that
look it
what
up.
you said again? On the PDF thing you got there?
Yeah, I got it.
Got it? What's her pain score?
Yes, sir.
Did you put a pain score down?
I don't record pain scores, no.
What's noted on your progress note?
Um,
On,
I'm not sure what you're referring to. Should not able to provide a review assistance. Is that what you mean?
under
Patient on
objective,
vent and not able to provide. I can read the examination if that's what you want. Not alert or attentive, not interactive, no
Hey,
purposeful movements.
Doc, relax for a second.
Yeah.
your note starts on one page, right, on November 13th, 2018? On page 80?
I've got page 82. I go to page 80 here.
Go to where your note starts.
Yeah, I believe my note starts on page 82.
Okay. And does it end with an examination of the extremities and then a listing of her maladies? That page. Extremities. No clubbing,
That's
stenosis,
page-
mild.
That's no clubbing, stenosis, mild here. That's page 82 for me. Yeah.
Yeah, okay. And does your note continue on the next page?
Yes.
And does it start at the top with DM, meaning diabetes mellitus?
That's right.
Okay, now go down there. Is there a pain score recorded on this document, this progress note?
Objection, Your Honor. He's indicated he
I
doesn't
see
take
it.
pain scores.
Okay, we got an objection.
He doesn't take pain scores, and I would ask the state to look at the date next to that, because it doesn't correlate with the note you're asking.
Okay. Note the objection, overruled. Go ahead, Mr. Zion.
All right. So as part of your review of these documents, did you note that on 11/13, on the same day as this, what her pain score was?
This information is pre-populated. So it says pain score 0, and that would be consistent with what I saw on my exam, I
Note your
suppose.
objection.
All right. So you don't do pain scores, but is that consistent with what you saw?
Yeah, right.
All right. And it was referred to on cross-examination as the medical administration records. I think we meant the medication administration records, the MARS. That's the part of the 1,000 or so page document that lists all the medication she would have received. Is that correct?
Yeah, that's what a MAR is. That's correct.
All right. And when you wrote your summary, just so we're very clear, you did not turn to the back there to see what the ICU doctor that evening dosed her with during her palliative extubation. Is that right?
No, no, I would not have.
As far as the amount of fentanyl and or midazolam?
That's correct. I would not have reviewed that.
All right. And following up on what the said on cross, do you assume good intentions in those you work with?
Yes.
With the doctors?
Yes.
With the nurses?
Yes.
With everyone?
Yes.
When writing your discharge summary and signing that death certificate, were you assuming good intentions of everyone you worked with?
Yes.
Thank you. I have nothing further.
Yes.
Okay. Thank you, doctor. We're going to shut you down. Appreciate
Thank
you.
you. Thank you.
Okay. Are we ready to bring back the other witness?
I think we are, yes, Your Honor.
This young man will lead you up. Right there.
I'm sorry. Oh, Dave.
I was being nice, he's younger than me. Gray hair, but younger. Okay, ma'am, you're still under oath? Go ahead and get yourself comfortable. Remember, speak loudly. Mr. Baez.
Thank you, Your Honor. Good afternoon, ma'am.
Okay.
Speed round is over, okay?
Right?
All right. I wanted to backtrack for a little
So you're
bit.
done? You said it was over.
I said speed round was over, Judge. So I wanted to backtrack just a bit, so since we're not in a rush, to kind of bring us up to speed on some things. Now, Miss McDonald had ovarian cancer, correct?
Correct, stage 4.
And that's out of how many stages?
4.
Okay. So she was pretty sick to begin with.
Correct, it had spread into her lymph nodes and into her liver.
Okay, and that's when she was directed to come to the hospital because of her elevated liver enzymes, correct?
Correct, they felt that it was from the clinical trial that she was on, those medications that she was on.
Okay, and then subsequent to that, her conditions just seemed to get worse and worse, is that correct?
Yes, after she was there for a couple of days, her liver enzymes just kept getting worse, and then she became more and more acidotic.
Let me stop you there.
Sorry.
When you say acidotic, are you referring to her lactic acidosis?
I'm referring to her pH and her lactic acidosis.
Okay, we're going to go into that in just a second. Talking about pH first. Are you familiar with the scale, the pH scale, and what's considered sustainable with life and what's not?
In some sense,
Okay. And you're aware that she was at a 6.9, correct?
Yeah, she was 6.8, 6.9, which is usually not sustainable with life.
Okay. That, and normal should be around 7.4, correct?
Correct.
So she's at that very end of the scale before someone passes away.
Right, and your organs do not like that. They will shut down when you are that acidotic.
And she already has issues with cancer in her organs, correct?
Correct.
Specifically her liver, that it moved over to that area?
Correct.
Correct. And then she also suffered a pulmonary embolism, correct?
Oh, yes, that's what the CAT scan found. When they had sent her to the CAT scan that night, they found that she had blood clots in her lungs.
And that would make it difficult for one to breathe.
Correct.
And would that also create or could contribute to a death rattle?
I mean, it could, yes.
Okay. Now, let's talk about her lactic acid. That was at a 27.
Yes, very, very high.
And when you say very, very high, that's because normal should be at 1.
Correct.
And it is considered deadly if you're at 10.
Correct.
But she was at a 27.
Yes, and that was the highest I've ever seen on any of my patients.
Okay. Now, she also was attempting dialysis, correct?
Yes, so the nephrologist had come to see her. They were a little worried, from what I could tell from the notes, that maybe the metformin that she took for her diabetes was causing her to be so acidotic. So they were trying to dialyze her to get any of that extra out. I think the nephrologist's note had said something along the lines of, basically, we have to try, because she was so young, they have to try to see if that's what it was.
And you testified under direct examination that the doctor on the floor had noticed that she needed to be intubated, so called over to the ICU to see if they might be able to see her sooner.
No, he came. The floor doctor came to the ICU and talked to Dr. Husel, because normally you would have to, normally there's a time frame, right? Like you would have to put in orders, and you would have to get a bed, and you would have to get report, and it would take some time to do. So he came and he was talking to Dr. Husel and was telling him how sick she was. And Dr. Husel was like, just bring her now, we will take care of her. So he, in essence, saved her life at that point, because he was like, bring her now, we'll take care of her. And he did. He intubated her within like 2 minutes.
So, and of course, the person who did the emergency intubation was Dr. Husel.
Correct.
And her condition continued to worsen, is that correct?
Correct. Throughout the day, it got worse
Now,
and worse.
I'd like to take you to the situation when finally a conversation was had with the family. Prior to Dr. Husel and yourself speaking with the family, other doctors had advised her of her condition, correct?
Correct. They had spoken with the family. It looked like multiple doctors had spoken with the family about how sick she was.
And all of them had discussed the potential that Ms. McDonald might pass?
Yes.
Okay. And now I'd like to discuss with you the conversation that you had with the family. Did you request for Dr. Husel to come and speak with the family at a certain point?
I let Dr. Husel know about her lab work and what her last blood pressures were, basically letting him know that she's not getting any better, she's getting worse. And he, from my notes, it said that he was calling the family, or the family might have been in the waiting room. I don't remember. So we both spoke with the family after they came in.
Now, what was Dr. Husel's demeanor when he spoke with the family?
I mean, very caring. He's an amazing doctor. So, I mean, he was definitely very caring with him. He discussed with them different options, whether or not they wanted to keep her as a DNR CCA, and we would continue to do the same things that we were doing, or did they want to go ahead and...
It's not hearsay. Let's go sidebar on this one since you said words. Ladies and gentlemen, let's get busy. You're in the final stretch.
So I have my own bathroom, my own tub, my own pop
Oh, you don't have my popcorns. Make good trouble.
Okay. Ladies and gentlemen of the jury, you're to strike the last question and answer, disregard it. New question.
I just want you to tell me Dr. Husel's demeanor, not what he
Oh,
said.
the whole thing, okay, so sorry. He was very caring, was his demeanor.
The conversation that you and Dr. Husel had with the family, was it a thorough conversation?
I believe so.
Okay. Did you convey to the family all of the options that they had available?
I didn't, Dr. Husel did. Yep.
Sustained.
If Dr. Husel had not given them all of the options, do you, in your custom and practice, would you fill in the blanks, for lack of a better phrase?
I would have discussed different options with the family, just so they had an idea of what we were looking at.
But you didn't find it necessary to do so in Brandy McDonald's case, correct?
No, they had already decided code status before I had gotten there, and then,
But the conversation that the two of you had with the family, you didn't find it necessary to add to anything
no,
that wasn't conveyed to the family?
correct, no.
Okay. All right. And then you mentioned under direct examination that you verified the dose amounts with two different nurses. Is that correct?
I verified the dose amount with with my charge nurse.
Let me stop you there. Which is a supervisor of sorts, correct?
Correct.
Okay. And go ahead.
I don't remember my whole conversation with the other nurse at the Pyxis, but obviously he knew how much I was giving because he went and got me a bigger syringe.
Okay. And at no time did either one of those individuals stop you from...
Finish your question.
At no time did either one of those individuals stop you from administering the dose or pose any issues with it?
Well, now you're getting compound on me.
Okay, I'll just
Sustained.
stop. Okay. At no time did either one of those nurses stop you?
No, correct.
And at no time did either one of those nurses convey any displeasure or questions about the dose?
Correct.
Now, another factor, there are numerous factors that go into, strike that. The other thing that I'd like to point out is Miss McDonald, her weight was listed at 273 pounds, correct?
I think she, in the end, when she came to the unit, she was 131 kilograms, so I thought that was closer to 280 something, but around there, yes.
Okay. Close to 300 pounds.
Correct.
Okay. And her BMI was 40?
If that's what the chart says, I don't know how to do that in my head.
Okay. Now, that is relevant in a dose amount, is it not?
Correct.
Okay. And that is because fentanyl likes the extra weight, is it not?
I don't know.
Okay, she
I'll
doesn't
withdraw.
know. Do you still want the objection?
I'll withdraw the question, Judge. Now, where we were earlier, I want to go back briefly to where we were earlier. Do you recall we were able to establish that the vent was set at 34?
Correct.
Okay. I'm now going to show you again Joint Exhibit 5, page 286 to 287. Do you see that?
Correct.
And the vent was set at 34.
You just went through this the first session.
Yes, I'm going back to finish my point, Judge.
Okay, well, let's go to your point then.
Yes. And that was at 11:40 in the morning, correct?
Correct.
Now, this only charts from 6:36 p.m. And we discussed her breathing over the vent, correct?
Correct.
And the palliative withdrawal. Now, just before the palliative withdrawal, she was at a 30. Do you see that?
This is around, because when I can tell from the other charting what the saturations were, that when I pulled the vitals over at 2131 or 2130, that I had already extubated her. So that 30 is most likely right after I had extubated her.
Okay. So she was breathing over the vent initially, correct? And what time do you have the extubation
I'm so
at?
sorry. Extubation is 2151. I don't know why she was breathing at 30.
Yeah, that's what I was.
Wait a minute, I don't know.
That's what I was getting at. So she went from over breathing for multiple hours. Let me see. That's 4 hours, approximately. Correct? Mm-hmm. And you have to say yes for the court.
Oh, sorry. Yes.
Okay. And then before the extubation, I guess what is that? 20 minutes beforehand. 21 minutes beforehand, she was breathing at 30, correct?
Correct.
She's not breathing over the vent anymore.
No.
Fair to say she was tiring out at that time, or that's what the records indicate.
Sustained.
The records indicate her breathing went down.
Correct.
Okay. And then after being extubated, she's at a 19.
Correct. And then she was at a 20.
And then 5 minutes or 4 minutes later, she goes up to a 20, correct?
So obviously the fentanyl didn't affect her respiratory
Okay,
rate.
sustained, there's no question.
Is there any,
Sorry.
I'll rephrase it, or I'll ask this way. Was there anything to indicate to you that the fentanyl in the records indicated, affected her respiratory rate?
No.
Sustained, disregard, ladies and gentlemen.
As part of your job, you were to monitor a person who's taken off a vent as to how they react. Is it not part of your custom and practice?
Yes.
Okay. And that's also why you chart a lot of this information, correct?
Correct.
So this is your job to make, and one of the things you look for are the reactions to medications, correct?
Correct.
In fact, that is part of your job, that you have to see if there are any adverse reactions to medications.
Correct.
So in this situation, you did not note or did not see any adverse reactions to.
Sustained.
Is there anything?
Sidebar?
If you insist, but
Well,
I'm trying to get around it.
you can't, though,
Okay.
the way you're going at it.
Then I would like a second.
Okay. How you guys doing? We're gonna go sidebar. I don't know where David's at. He's back behind me. I can see him in the corner of my eye. You've just been so efficient today. Tell me when you're ready. Ladies and gentlemen, you disregard the last question and answer. Next question.
My last question on that topic is there anything in the records to indicate to you that she had an adverse reaction to the medication?
No.
Sustain.
I thought that was what we agreed upon.
No.
All right, I'll move on.
If she saw any adverse reactions, that's what we agreed to.
I'm sorry?
If she saw any adverse reactions, that's what we agreed to.
I've moved to strike the last answer as well.
We'll strike the last answer. You want to ask the question this time?
Yes, sir. I apologize for the misunderstanding. Did you see any adverse reaction to the medication?
Objection.
Sustain.
I'm sorry, Judge.
Did you see any adverse reaction?
No.
Next question.
Okay. Thank you, Judge. Now, you mentioned that in direct examination that the purpose of giving the pain meds was to prevent Ms. McDonald from suffocating to death. Is that correct?
From feeling herself suffocate to death.
I'm sorry, can you say that again?
From feeling herself suffocate to death.
Okay. And that was your intent when you administered this medication, correct?
My intent was that she would not feel herself suffocate to death when I removed her from the ventilator.
You did not intend on harming her in any way, shape, or form, did you?
No, I didn't.
Okay. And that was always your intent?
Correct.
And you never conspired or agreed with Dr. Husel to...
Sustain. Let's rephrase it.
I just want to ask that was your sole intention, to make her comfortable in comfort care?
Correct. That was, yes.
I have no further questions. Thank you, Judge.
Redirect.
Just briefly. On State's Exhibit 5G, defense counsel asked you, you had entered that note correctly. What time did you enter the note, if you recall?
It should be when I entered the order itself, which I believe is 2131.
Is that the 012, does that correspond with the pain score right here?
Yes.
And what time is that?
2151.
And was that before or after you had removed the medication from the Pyxis machine?
That was after, but it was the order that I wrote. Like if you go to medication orders, the ones that I actually wrote, you'll see where I have that on there.
Can you say whether or not the pharmacist actually saw the
They
notes
should
you
have
entered?
if they were doing their job.
Okay, so you can't say?
No, I can't.
That was argumentative. You can't do that.
Sorry.
Okay? You can only tell us what you know, what you've seen, what you observed through your senses.
Going back to this page that defense counsel showed you, is it fair to say that her respiratory rate was going up and down continuously over this time period?
With
Objection leading.
I'll permit it.
while she was on the ventilator? Is that what you're asking?
Yes, over this time period shown here.
It was, her respiratory rate was elevated.
But it was
That's not what you're
going,
asking.
so it started at 39, did it then go down at any point?
Yeah, so it went down to 36 and then back up to 38, 35, 32, so
And then did it go back up again?
32, 37.
And
Yes.
then did it go back down again?
Yes.
Is that, can you say if that's correlated or not to what was going on, how you're talking about her overbreathing and tiring out?
Yes.
the ups and downs. Can you explain that a little bit?
So the 38, the 36, all of those, so she's over-breathing the vent at that time, showing some distress. Like I charted, she was guppy breathing, so she was over the vent. I'm not sure, could you ask the question again? I think I got lost.
I think you explained it well, thank you. At any point while that was going on, did anyone from her family approach you with concerns about her breathing?
I don't remember.
Did anyone from her family approach you to say that she appeared to be in pain?
I don't remember.
Had you treated her for pain at any point on your shift that night prior to the 1,000 micrograms?
I don't know.
Showing you the medication administration from that night, States Exhibit 5H.
You're getting outside the scope, aren't you?
I'm going to pull it back in, actually, right here.
Okay.
Defense counsel asked you about factors that you need to consider when dosing. Is that correct? Do you remember that?
Objection, Judge. I just asked her about a weight.
Let's rephrase the question.
Did the defense counsel ask you about any of the factors relevant that you must consider when dosing medication?
I don't dose medication.
When considering, is it your job to consider whether a doctor's dose is appropriate or not before you administer it?
Yes.
And what factors would you consider in that process?
Could be a lot of different things. Could be weight, what sort of medication she's on, or he or she is on, everything that's going on with the patient.
And do you recall testifying about her weight earlier?
Yes.
Would one of the things that you would have considered have been the fact that earlier in the evening she had received a 50 microgram dose of fentanyl and that the medication records indicated it was relieved, that her pain was relieved?
I don't remember knowing that she had received that or not.
Would that have been an appropriate factor to consider?
Objection. On the scope.
I would agree. Sustained.
No further questions.
Thank you. You may step down. I would go for another witness, but it's 8 till. You guys had enough of me today? Ladies and gentlemen, have a wonderful evening. We'll get started at 9 tomorrow.
All rise.
Remember the admonition? Let's get started promptly at 9, folks. Have a great evening. I don't know what it looks like outside, but hopefully it's nice. Real nice. I won't get to enjoy it, but that's okay. The seniority here.
Thank you, Your Honor. This has nothing to do with today's proceedings, but it does have to do with our expert, Dr. Schweiger, who is contemplating coming in midday next Monday, and I haven't got all the times yet, and then staying again overnight and being available most of the day Tuesday. So I just wanted to find out if the court thinks that staying a little past 5 with somebody coming in from Tampa on the one day to make sure we get him all done on the second day would be possible. I just wanted to, we obviously are trying to juggle the flights, and I'm just throwing it out there to see if you have any thoughts on that.
Do we know approximately what time he's coming in Monday?
I'm trying to get that information now. I think they're contemplating him coming in the morning and being available for examination here in the afternoon, and then finishing testimony the next day.
Did he review all 14 of the records?
He did. He did.
How long do you want to go past 5? Because the best thing I can do with the jury is, I need a favor from you.
Yeah,
Can we go a little past 5 on Monday?
yeah, I'm sure.
You know? But when we say a little, you know, half an hour is what you're talking about, an hour?
Yeah, probably no later than 6. Not this type of testimony. I mean, you know, it's a lot.
It's a grind on them.
Yes, it is, I agree.
Are we better off just to get him started earlier, if he can get in?
I'll work with them to the best of my ability. I just don't want to be in a situation where he's looking at a 3rd day.
Well, the question becomes is what do we do on day 2?
Yeah, I know.
Are you leading this exam?
I am.
Okay. Estimate.
Today because we weren't going to get them. But we didn't want to run out of witnesses, so we have people out in the hall.
Well, I think we got a lot done today, irregardless of how many times we asked the same question. But that's beside the point. Sorry, that's just me having a long day and being reactionary. I apologize.
Judge, if we could just go back to the conversation, just don't want to find myself where the state has the afternoon of Monday, and then the morning of Tuesday, we go to lunch, and then I have the afternoon, and I feel pressed or rushed. I just put that out there. I will be efficient, but, you know, we would run into a similar situation if I feel like I only have a short period of time after the state has had extended. But I'll do my best. I mean, I'm efficient
Well,
if nothing else.
let me ask this of everybody.
He talks a lot based on his depo.
Yeah.
So.
Okay, that aside, can we agree to a CV and just stipulate a CV?
I think we just forwarded the updated CD. You know, it's typical that.
Yeah,
I mean, I'm just trying to save steps. I'm not saying you have to volunteer. It's still my decision on whether he's an expert or not.
Sure.
If he makes the gate, but if he's got the minimum requirements, you know what my reaction will be. It's up to their weight and credibility they give him. Now, I imagine you guys will want to go through some, but instead of spending an hour or two just arguing over the CV, I didn't know if we could just shorten it up or what.
I don't think we spent much time on Dr. Ely's, did we?
Well, indirectly and directly. To get to the expert side of it, we didn't spend a lot of time. But it doesn't sound like this guy isn't going to be able to opine if he's got the credentials.
He's got his
So all it is weight credibility. We'll get the arguments for her.
I mean, I think Diane and I will wrap it up in short order, as short as it can be.
I think we're better to save it in day 2. Hopefully we can get it through your direct on day 1. And then she starts out at 9 o'clock in the morning going at it.
Yeah.
That'll take her through the lunch hour, and that'd give you a couple hours at the end.
Yeah, okay.
If it stays true to form.
Sorry for interrupting. I just have to figure out when he can be at the airport. They didn't indicate what the flight times were and the email.
Well, if he gets in at 3 in the afternoon, we're screwed.
Right. Right. So we need good weather, an early flight to get him here on Monday.
It would behoove us to do that. Otherwise, he's here stuck an extra day.
Yeah, I know. I'll try to nail that down. I just got the email as basically as you were excusing the jury, and I'm trying to reply now. I didn't want to lose the opportunity to address it this evening before we went away.
I've been more than glad to work with people in scheduling and getting things up. We move people around, whatever it takes. On the other hand, I don't want somebody to feel like they're being shortchanged.
I understand. I don't want that either. So I'll work on that overnight and see what I can.
Okay. We can talk about it first thing or something, or you guys can talk about it ahead of time and then talk to me.
We did have another issue that we wanted to talk about with relating to the families. Almost all of them are or have been involved in civil litigation involving the hospital and other defendants. And we wanted some guidance on what questions we were going to be permitted to ask or not ask before we got started with them as witnesses. Obviously, we're not going to be presenting any tonight, but if the court could give us some guidance tomorrow.
Well, I think it's perfectly relevant what they went through at the hospital, the explanations that were given to them, the completeness or lack thereof, you know, all the factors that went into their interaction with any of the Mount Carmel staff. I think that's all perfectly relevant.
Okay, we're concerned with, you know, the information that could be elicited regarding the civil suits.
Well, as it goes along that line, I think it's perfect game in this one.
Okay.
That anything that goes there. Now, any mention of damages is totally inappropriate.
Understand.
Okay? We're not talking about, well, you made a demand of $50 million. No. Unless you can show me some case law about bias there, but that's a demand made by a lawyer. So I don't know if you guys are going to load those things up, but I find it hard pressed. I think it's misleading at that point in time, since it was done by another person representing them. But I don't see how it doesn't. I think it's more prejudicial than it is reliable for the jury to consider. I mean, I don't see a problem with them saying, isn't it true you have a civil suit? So you're seeking money, period. I think that's fair, but once you start getting into dollar amounts and breakdowns of settlement demands and things like that, I think it's just too far. I think the prejudicial effect outweighs. Okay?
So a couple questions about it. I can think of at least one instance where I think if the proper foundation is laid, there's someone that will testify to one thing which is contrary to what's said in the complaint that's been filed. Now, I understand an attorney's drafting the complaint, but if a proper foundation is laid, did you file a complaint in this case before it was filed? Did you review it? Are you familiar with the statements in that complaint? You know, did you have an opportunity to correct them? I think that that complaint could be used for impeachment purposes. And specifically with one person, it's an important point. So it's my witness, so I'll heads up when I think we get there. But I think the complaint could be relevant in that way. Also, though, just so we're clear about cases that are pending, I think there is a bias issue as to a conviction in this case would help with any civil judgment after this. I think that's relevant with respect to bias. I also just want clarification on, is the court saying that we couldn't elicit testimony? Did you file a lawsuit against these individuals? And isn't it true that that suit was settled? You're saying we can't get into that?
If it involves the financial, I don't see where it's relevant.
Okay, so your opinion is no money, no dollars whatsoever?
I don't mind that it's mentioned that the lawsuit was filed because I think that's proper as to bias. But as to what a settlement is, those are all confidential.
No, they're not
usually.
confidential, they're on the probate court's records. I mean, they're public, what the amounts were.
Okay. These are the wrongful death parts of them, right?
Mm-hmm.
Okay.
I
Does that include all the claims?
It includes every claim except for, I believe there's one still pending. A claim, by that you mean an open suit? Like a,
An open suit, yeah.
that's correct. I think they've been resolved, but for one that's set for trial. Might be more than one, but one in particular.
There are currently, I think, 6 set for trial in this court.
Okay, so
But they may not all be these counts.
and I think of what's left, there's one that's outstanding. That said, I'm preparing, kind of day by day, so I might not be accurate on that.
I will think about it tonight,
Okay.
okay? My gut is I don't have a problem mentioning there's a lawsuit seeking damages, but that's about the extent of it on my gut.
Okay, I would ask the court to consider this then. For any case that's still pending, I believe the fact that a conviction in this case, asking that question about, isn't it true, you believe that a conviction in this case would be helpful in your civil case?
But that's only one case, right? One
case
witness.
that I know of, that's correct. Yeah, I think that goes to bias and motivation.
I'll think about it.
Thank you.
Anything else on that issue?
Janet was asking Tim.
Tim, I don't think so. Thank you, Your Honor. I was just contemplating that question.
Well, I am too.
Diane just posed.
I mean, there's a lot of things I get through my mind on the issue because it's a pitfall at 4 or 3 one way or the other.
I think I'll just defer to the court on the whole thing.
Well,
Because
I don't know yet on what I want to do, okay?
actually, yeah, I understand, and I'd be making a comment. Following all the civil suits, all the ins and outs, I have no idea which one she's talking about or what the problem is. I just don't know.
Okay, well, because of Marcy's law, I'm also worried about, does that witness then have the right to have counsel present and to advise her or him? Because you're talking about an impact to the victim. And that's in the back of my head. Okay? You're looking at me like I'm crazy or
I'm
just...
contemplating that, but it's a public record. Your case is pending, set for trial. I mean, and I guess
I
it's
understand. I'm not saying yes or no to you
Okay.
yet. I'm contemplating it. But in the back of my head, I'm also contemplating about what right to attorney is this person going to need.
Okay. Well, I'm happy to provide the name of the witness to the state and make sure that that person has their attorney here since the case
Okay.
is still pending.
That would be helpful.
Sure.
Yeah.
We would appreciate that.
And that's the only one that fits into this category of pending?
That I know of right now, Your Honor. But I'll let the state know.
Are you bringing the family mostly Wednesday, Thursday this week?
To be honest, Your Honor, we're filling in where possible. We're just not wanting to waste any of the court's or jury's time, so if we feel that we can bring some family members in after the healthcare workers, we'll bring them in. It's, as you know, with healthcare workers, you can't stack them up out in the hall because they're all taking care of somebody's health somewhere, so it's a juggling, and we're doing our best to fit them in. We had one here today, or available today, and we never reached him. So he'll be, cycled into the next day. And we really want to finish early next week, if at all possible. So we're looking at the finish line.
Okay. Anything else?